The topic was maxillary reconstruction, bridging concept with wisdom. So I'll just go along with what you told me. So I'll do the concepts first and then go to some amount of practical issues, practical things which you have learned over the period of time. Now, see, if you look at the maxillary reconstruction, which is least less understood than mandibular, uh, we owe a lot to the people who have worked on it, especially James Brown as well as Peter Cordero, who put the classification systems in place, which allowed us to analyze the defects well and plan the reconstruction. And we use the James Brown classification because it encompasses most of the defects which we see, and as well as allow us to plan the reconstruction. Now, in this talk, I will just go through few of the defects which are commonly seen by all of us: maxillectomy needing orbital support, orbital accentration, as well as bilateral maxillectomy. Now, what are the reconstructive requirements in a maxillary defect? This is something which you should all look at before you embark on any particular case of maxilla for reconstruction. The first and foremost, I would say, oronasal or oroantral separation. That is the primary thing which allows you to not use a large obturator. Orbital support in a preserved orbit, orbital cover in a accentrated orbit, additional to oronasal separation, as well as dental rehabilitation. And the last one, the aesthetic one, will be the last thing which you should take into account when you look at the requirements. What are the options available? A lot of things are available, including the time-honored obturators. Obturator can be with a denture. Loco-regional flaps like palatal flap, temporalis, buccal pad, nasolabial, coronoid, temporalis, or even reverse submental flap has been described in a very beautiful way for a maxillary reconstruction. Free flaps, it can be soft tissue or bone. Out of the bones, DCA and fibula are the commonest ones which have been used. Now, coming to the common defects, their reconstructive requirements and options, I would say that the first one is a simple infrastructure maxillectomy or a total maxillectomy, where the requirement is oronasal separation and alveolar, if needed, alveolar bony reconstruction. Now, oronasal separation can be achieved by a lot of things. This is a simple radial forearm flap. This is a fibula with a bone flap where skin is used for oronasal separation. DCAA with the muscle, internal oblique muscle, also will help you do that. And in cases where this is the simplest one, is using a temporalis myofascial flap, which will obliterate the defect. Coming to the maxillectomy with orbital support, here it is much more difficult than the other one. So you want to have a oronasal separation, that is the primary one, and you have to provide orbital support. You can use a mesh and rectus abdominis or any soft tissue flap. I mean, you can have an ALT flap, you can have radial forearm, or anything. But the principle would be you have to have a lot of things kept in mind when you use a mesh, which I will come to later on. But it has to be on principle covered by soft tissue. Second one is using a bone for the bone, like a fibula. This segment of bone can support the orbit, which you can see here. You can have again this part of the bone is for the orbital support, which works very well. And you can see the bone which is supporting the orbit. I'll come to that later on, this orbital support later on, what are the issues and what are the choices. This is a flap which we designed and executed using the tensor fascial lata with the iliac crest, which supports the orbit with the bone. Now, coming to maxillectomy with orbital accentration, apart from the oronasal separation, your requirement is full orbital coverage for the whole defect, out of which I would say the commonest method can be a soft tissue free flap like a ALT or rectus abdominis flap, or you can use complex methods like this, which we described the composite flap of ilia crest with the internal oblique with the rectus with the tensor fasciolata, providing bony support for ocular processes, or this method. This was a slide borrowed from Satparmar, using an entire iliac crest to support the orbit, and then you use the muscle to cover the orbit as well as the palate. So again, the advantage is that you can use an ocular processes. Lastly, the common defect which everybody is dreading to reconstruct is a bilateral maxillectomy defect, where apart from the oronasal separation, dental rehabilitation and aesthesis is important, because a bilateral defect causes a lot of deformity. Zygomatic implants with the obturator is one option available. Free bone flaps or soft tissue alone, which is difficult to give a aesthetically pleasing result because of lack of support of the nose, as well as difficulty to put dentures. So I would say at present, for a bilateral defect, the fibula flap is the choice of choice flap, which can provide the support as well as oronasal separation. Now, when will you choose to do a reconstruction and not operate? To our In our unit, the guiding principle is this. See, you have a small defect. Here, to have a large obturator is bad. Or you have a too large a defect where the obturator can be done, but it is a huge one where the patient has to use every day. Or a patient with a trismus where you cannot fabricate the processes or put it in a day-to-day basis, or a bilateral maxillectomy defect. So these will definitely be a priority indication for reconstruction, compared to obturation. Now, coming to certain points which become difficult, or to which are something of importance when you look at the maxillary reconstruction. As I told you, mandibular reconstruction has evolved a lot, and most of the people can execute a mandibular defect reconstruction to a greatly in a very good way, whereas maxillary reconstruction is still, I would say, in infancy because of a lot of difficulties. I'll just go through few of the points which I would say we learned over a period of years and years of experience with maxilla. We started way back in 2004 or so. So a lot of experience in this, which has made us more wise, because wise people will think that there are problems with anything what you do. So nothing is very easy in maxilla. Dental rehabilitation. Now you have to assume that these are important things, that dentures are the common methods even now. Whereas in mandible, it has evolved to implants, full implants, or implant-based dentures. Whereas in maxilla, still I would say a denture, ordinary denture after a obturation, oronasal separation is still the method you choose in many cases. Now, how do you help in your reconstruction? See, look at here. You have to create a sulcus for the dental rehabilitation. See, in this, there is no sulcus. In this, you have used a muscle. There is no sulcus there. It is impossible to place a denture there. Whereas you look at here, same thing with a soft tissue flap. You put it in so that there is a sulcus there where you can put a simple denture. And this is the girl who had a denture. There is no implant. It's just simple denture giving her adequate dental rehabilitation. Avoid sagging is Avoiding sagging is very important. This is a muscle flap. This is a skin flap, and this is a radial forearm flap. You look at the sagging here. Nothing will be possible to be placed if it is a sagging flap. So maybe you should have it very tight and going up into the sulcus and coming down. That will be the way you would make a soft tissue flap. Better sulcus for denture, simple. If you put a bone there, it doesn't mean that you should put implants. But this bone will allow you to create a sulcus where a denture can be placed. So putting a bone in the alveolus is good even for that. Implants can be used, like in this case, you can say, as I told you, implants can be placed to assist your dental rehabilitation, which you can, implant assisted dentures can be used. Whether it will help chewing is a very, very significant thing to think about, because you put it mostly, if you look at most of the patients, except for the bilateral cases where you put a lot of implants or a lot of thing, they might use the for chewing. Now, look at this. See, your alveolus is like that. It goes like this. You can stop short here for your denture or whatever is that. But unless you have a zygomatic connection, here the bone goes like that into the zygoma. The problem here is that the position of the bone is not congenial for that real placement of denture or implants. Whereas here the position is congenial, but the support won't be there. So you put a bone here like this so that the weight transmission later on is into the zygomatic buttress. So this is a very key area if you want to make the patient use a denture with a maxillary reconstruction to have this connection there. Bone placement, alveolar replacement, these are the purposes, nasal support, orbital support, and this is for aesthesis. Alveolar placement, see, it's one of the most difficult things in maxilla is because of the shape of the maxilla. This is the alveolus, this is the nasal support. You want to have both in a way. If you just put a fibula here, it doesn't work. If you put a fibula here, this doesn't work. So that is a problem with the bone placement. You can see as a replacement, this is the right position. And how do you put that maxilla in the right position is by inverse planning with the mandible as the key. So you have the inverse planning of the maxilla, mandible being made here. You can see the picture. So you can see this will show you the way that fibula was fashioned for that. This is a mandible position. This is the maxillary teeth position, and you want to have the bone here. So that is the way you do it, and then you can see the bone being placed, and then exactly there. So you have the sulcus recreated, and this is him dentally rehabilitated now. Nasal support is another difficult area. The key is to have, see, the bone anteriorly or put a support for the columella. This nasal part was essential in this particular patient, but that might not be needed in all the patients. But this area is important. Having the bone anteriorly or a columella support like that is essential for providing nasal support. Orbital support is the most difficult thing. You can have fibula, scapula, all these things. You can have a mesh, you can have a coronary temporalis. These are all the methods. Out of which, see, you look at it, these are the bones which have been placed very nicely. I am showing you only the nice results. There are a lot of poor results you get. So if you look at it, the orbital support by a bone is not as easy as what we think. See, this thing here, it is like this, and the problem is that fibula, if you have a total loss of the orbital floor, the fibula supports only the anterior portion. So posteriorly it can sag like a blowout fracture. The best way there would be to have the mesh also used along with that. The advantage here over the conventional mesh is that this mesh need not come anteriorly because the bone is there. The infraorbital, the mesh usually fails in the infraorbital rim where it is subcutaneous. You can place the mesh in a fibular reconstruction posteriorly so that it doesn't extrude out. I would say even now, mesh with a soft tissue flap is the easiest thing for a orbital floor support. The key features here, you should never bring it too much anteriorly so that it comes out of the skin. You should supported with good soft tissue from below. Above is the orbit, below should be a good soft tissue. But, and if you're using a fibula, think of putting another mesh, small mesh, to support the globe posteriorly. 3D planning is quite useful, very useful in maxilla. I would say mandible, we can all eyeball, you can make it, and that you can make it, unless it is an expanded mandible, you would be able to pre-plate it and make it. Whereas in maxilla, it is better to have a 3D model. You need to have sophisticated thing. You just need to get a printout model, and you can do, your own way. This is the inverse planning which I showed you. You can take the fibula, you can take a model of the fibula, cut it, cutting guides, and then finally get it there, and then get it like this. So 3D planning plays a role. Lastly, I'll show you one picture which show you everything. This is a total maxillectomy in a girl. Now, the 3D reconstruction allows you to have this orbit placed. This is the alveolus. This is the buttress, which I told you, reconstructing the buttress. This alveolus bone is placed in such a way that when tooth comes here, it matches the mandible. And in this picture, you see the orbit being addressed by a mesh also. So I would say this picture, this case will illustrate all the aspects, almost all the aspects which you need which I emphasize. That is the 3D planning, placement of the alveolus, the buttress, placement of the orbit, and placement of the mesh. And then this is the patient. This is a pre-op. This is a post-op. I think it will fulfill. And we have not placed the implants. We can place the implant once she is fully more mature and older enough. So even the denture will create it. So I think I've covered the wisdom part also. Thank you very much.
Thank you, Professor Iyer. If anybody have any questions, they can put it in the chat box. But while we're waiting for some questions, Dr. Iyer, can we go back to your first slide regarding to the classification of the maxilla?
I'm coming there. Yeah. The classification system. James Brown?
Yes. It was a wonderful talk, excellent talk. Yeah. I loved your tips on bone placement, on importance of orbital support, and also important 3D planning. But why would you choose this particular classification? Do you have any personal tips on that, Dr.
Yeah, I would say I have been both the competition is between Cordero and James Brown, if you look at the literature. See, because they think both are good friends of mine, so I cannot say that it's personal sort of anything, right? But James Brown's classification, I would say, is more complete, whereas Cordero classification is simple, very simple. It relates to what you say. Infrastructure maxillectomy, total maxillectomy with this thing. But what James did was smartly put that horizontal and vertical component. So that this will encompass most of the defects. Still, the deficiency with the James Brown classification, if you look at it, there is no bilateral defect there. You look at it, it is not there. So you have to combine those. So that is one deficit. And if there is an extensive skin defect, it is not there. So these are the deficiencies there. Still, I would say James Brown classification would help us to compare our defects and all those things. There is no ambiguity here in this. And so I think I would still continue. We are still using it.
Oh, so
and I would just add that OK's, if you are very keen, OK's classification also you have to look at it, which looks at the prosthodontic point of view, placement of dentures, the stability, as well as placement of what defects need reconstruction from the prosthodontic point of view is given in by OK's classification.
OK's classification. So it's best to know all three classifications, then choose the one you're comfortable with from your practical experience.
Correct.
Some more questions, okay. from Dr. Johnny Uday. He says, what do you think about personalized implants made out of PEEK of titanium?
See, personalized implants are coming in a big way in everything, in temporomandibular joint and mandible with all those things, and then peak implants. We see in our department also, we have been starting to use personalized implants with the titanium, which is we can fashion it ourselves and then we send it for printing. So it's not that it's not difficult, but that is different. It's not the personalization of the implant. It is the use of the implant versus a autologous tissue. That is where you have to be careful. See, in a cancer where there is a chance of radiation, I would say 100 times no, no, no to the implants alone. But you can use a mesh, small mesh, not the huge thing which reconstruct the whole thing. It will come out definitely. Whatever is personalized or non-personalized, it will come out. So in those cases, no. Whereas in a smaller defect, a benign one, maybe there is a role for that. But I'm sure whatever implants we are using now will become personalized implant in future. Wherever you use a simple mandibular plate, simple maxillary, anything what you make, in another 5 years time it will be personalized, because it's so easy to make, easy to personalize, it's cheap to personalize now.
Thank you, Dr. Ed. One more question. There are two people, I think, asking very similar questions. One is Dr. Madhav Kitor and other one is Dr. Rajnikant Janakiraman. They say in the last case in your slide about the young girl, where was the vascular pedicle anastomosed? Or can you explain how
Yeah,
it's tunneled to the
yeah.
neck?
I had 3 slides. Vidya, you'll give me a minute, no? Will you give me a minute? I will. I have those slides of the pedicle placement. I didn't do it here. This is here. Let me unhide it. I was worried about the time. Pedicle placement is very important. I would say, yeah. See, pedicle placement is very important. Always, this is the problem with the maxillary reconstruction. The pedicle length, whatever flap. Why we choose fibula or radial forearm is because of the pedicle length. Why we don't do much of DCA for maxilla is because of the pedicle length. Now, or scapula. You have to dissect the facial vessels high up in the cheek, and 8 to 10 centimeters of distance is there. If you are see, under the mandible is 6 to 8 centimeters. Over the mandible will be more. To the superficial temporal, it is 5 to 6 centimeters. But this seems to be easy. But the problem here is the quality of the vessels in the superficial temporal area, as well as this tunneling is not good. The veins are not brilliant, because if you have a fibula coming here, it is going to be very difficult to match the vessels. So here, I wouldn't, personally, we use most of the thing always under the mandible into the neck rather than the superficial temporal. So to answer your question, we always, this is the way we do it, and usually comes there.
And Dr. Rajnikant is asking, I think the same case, would you need separate skin paddles for nasal cavity separation and oroantral separation? And
Yeah.
Dr. Jagdish Chandra says the same thing. How many paddles skin lining
No,
would you?
yeah, when we started, this is a question of the what you said about the wisdom, right? The problem is that when I started, we had that fancy. I have pictures of creating a separate paddle for the lateral nasal wall, another for this one, and eventually, when you look at it, your skin paddle for the nasal wall doesn't work very well. Even if you plan it so well, it cannot be hitched. It cannot be hitched posteriorly. It has to stay there. You cannot make it stay there, and you cannot make it so high up also. So when you look at it, none of your fist cavities are covered. No, you make a medial maxillectomy in fist and leave it like that. So I would say we have stopped the about the lateral nasal wall reconstruction with skin or anything. Unfortunately, if you use a muscle of the internal oblique or anything, that muscle bulges into the cavity. So it might be a problem where you will need to stent it to keep it patent. So on the whole, you don't do anything.
Okay. And Dr. Madhav Kitor says, are you concerned about exposure of titanium mesh in the nasal cavity and maxillary antrum? The
Uh,
titanium
yes, very much, very much. That is why I said if you are using a mesh, always make sure that you cover it entirely in the under surface with soft tissue. Don't leave it open. It will come out. And don't bring it medially too much into the nasal cavity. Try to limit it. Try to limit it from coming anteriorly or medially and support it nicely with some soft tissue so that it is not in contact with air in the maxillary cavity. Very important.
Last two questions. What is your choice of flap for suprastructure defect involving floor of orbit and a part of anterior wall done for a benign tumor? This is by Akshay, Dr. Akshay.
It's a very good question because we may have to do that. I had one case where I had some picture where we used the osteocutaneous radial forearm flap in those cases, in that case, because most of this will need a soft tissue cover, and you don't want to have a thick sort of thing. So there we used that, but I would say you could use a small, in these cases, a small iliac crest with some amount of muscle, which the internal oblique, very minimal, with connection to the superficial temporal might be good. Where you can shape that, the bone also along the lateral and the inferior rib.
Okay. And last question. If you're using zygoma implants and bilateral maxillectomy, what is your soft tissue free flap cover of your choice?
Anyway, either rectus or ALT. Either rectus or ALT is still the choice.
Yes,
Mostly ALT.
mostly ALT. Okay, so thank you very much. We will now go to the next talk,
Okay.
and I will introduce the next speaker. Uh, you can stop sharing your screen.
Yeah, I'll
Thank
do
you.
that. Stop share. Yeah.
Okay. So our next speaker is Professor Dr. Mohit Sharma, who is a professor in the Department of Plastic and Reconstructive Surgery, Burn Surgery, and Composite Tissue Allotransplantation and Reconstruction at Amrita Institute of Medical Sciences. Dr. Mohit Sharma completed basic medical training in SMS College, Jaipur in 1995. Followed by that, he did his master's in general surgery in the same institution. And then he completed his specialization in plastic and reconstructive surgery from the Safdarjung Hospital, New Delhi in 2002. Dr. Mohit Sharma is a St. Andrews Fellow in Burns and Hand Reconstructive Surgery from the United Kingdom. He did his fellowship in Broomfield Hospital. He has been working in the Amrita Institute since the year 2003, which is the state-of-the-art 1,200-bedded tertiary care center in the southern state of Kerala in India. He has vast experience in microvascular reconstructive surgery, ear reconstruction for facial paralysis, head and neck reconstruction, breast and genital reconstruction, and also he does a lot of surgeries for cleft lip and palate. He's also a proficient in lymphedema management, and he's now the leading in the field of vascularized composite allotransplantation in India. He has more than 40 publications to credit, and he's also been the part of the team for India's first bilateral hand transplant and tracheal transplant, along with Professor Iyer. His topic for today is mandible reconstruction, technical considerations for good reconstructive outcomes. Dr. Mohit Sharma, sir, Zoom platform is yours. You can share your presentation now. And just checking if Dr. Mohit is online.
Hello, Vidya, can you hear me?
Yeah, I can hear you, sir.
Yeah, I cannot start screen sharing till sir's thing is
Yeah.
off.
So do you want to try now? It's been stopped.
Yeah, okay, just is it?
We can see your screen. So,
Yeah, yeah, yeah.
uh, before
So,
you start,
Vidya, thank you very much for inviting me,
okay.
and it's a real pleasure to be with you. So, should I straight away start with the talk?
Yeah, definitely, sir. But before you start, I'll just request the participants again to mute your audio so that you can hear the presentation better. Thank you. Sir, you can please start. Thank you.
Just a minute. So, is it a full screen or the
You have to make it a slide share now.
slide share? How?
In the bottom right-hand side of the screen, there's a right hand side bottom, you can see that display picture there, a small icon.
Just a minute. Where? Just a minute. Where I see?
Or
Okay, just a minute.
sure,
Yeah, is it?
yes, we can see now.
Yeah, yeah.
Thank
Thank
you.
you. Thank you. So I'll just start this thing. Today we'll just consider all the technical aspects in by which we can have a good reconstructive outcome with the mandible. So this will be the outline of the talk in which we'll consider the planning of reconstruction, ideal positioning of the graft, controlling of the dentate and edentate proximal segments, the various fixation methods, and managing the soft tissues. So this is a typical case scenario in which we are doing the mandibular reconstruction and a large segment has to be reconstructed. So our first priority is to choose the correct bony tissue for the reconstruction along with the soft tissue, and especially when we are using fibula, there have been various publications that there is no side specificity for fibula. When we are doing, we can choose any side of fibula for any side of reconstruction. But if you want to have a appropriately placed skin paddle, there is a site and position specificity to some extent, which I'll show you just now. So this is a typical graphic diagram of a fibula in which this is the plating surface on the peroneal aspect. And the FHL comes, if you take the fibula, then the FHL comes on the inner aspect and the skin paddle with the septum is going on the outer aspect. We'll see the dynamics. So we did a study in which we took the fibula and kept it, both sides fibulas we took and kept it with the vascular pedicle ipsilateral posterior as well as anterior. So ipsilateral fibula with pedicle posterior, ipsilateral with anterior, and this shows us that the match is there if the ipsilateral fibula is there with pedicle anterior or contralateral fibula is there with pedicle posterior. So that helps us in understanding how do we take, because if the skin paddle is small, that becomes a significant consideration. So this is, we are taking the right sided fibula for left sided reconstruction. So we have to just turn it, and by turning it, if we if we place it in this fashion, we get the FHL inside and skin paddle on top very easily, and we can create lining very comfortably if we are taking the contralateral fibula. But if the same fibula we turn other way around, then the FHL goes into the submandibular surface and the skin paddle comes outside and the pedicle, vascular pedicle, comes anteriorly. In this particular situation, bringing the pedal inside becomes difficult, and also you cannot use the FHL muscle for intraoral reconstruction, and if you try to, then it will cause kinking of the pedicle. So this is the graphic way in which, in this situation, if you move the pedal, it is restricted, it cannot come inside properly if the ipsilateral fibula is used with the vascular pedicle posterior. So you have to use contralateral fibula. This is again, this shows this thing that in this particular thing, again, you see there is a limited mobility when the skin paddle is very small. Now, if we go with the vascular pedicle posterior and we are using the contralateral fibula, this is the particular way the pedal comes very easily inside the oral cavity that we have already seen. So that becomes important consideration. So important thing to remember is that if we are wanting the skin cover with the vascular pedicle posterior, we want skin cover outside, then we have to use ipsilateral fibula. Then SCI is the mnemonic which I made. And if you are using the mucosal lining, then we have to take contralateral fibula. Then we can just remember it by MLC. So only one thing that has to be remembered to understand this all jargon is that we are taking normally vascular pedicle on the posterior aspect. Then the mucosal lining will come from the contralateral fibula. And this is important because in this situation, we can take a very small skin paddle and we can either, if you are not taking the skin paddle, then we can directly close the site. If you are taking a very small skin paddle, we can close it by propeller flap and avoid a graft. That becomes very important for the donor site morbidity. So this is one aspect. Now, if you are doing the ramus reconstruction, and if we take the fibula and keep the vascular pedicle posterior, then it kinks. So generally, when we are doing the ramus reconstruction, we try to place the vascular pedicle anteriorly, and knowing the correct orientation of the fibula becomes important in this situation. Now, coming to the ideal position of the graft, whenever we are putting the bone graft, like we are using the fibula, the placement of the fibula is very important. If it drifts slightly outside, not correctly placed, then the implants have to be placed in a particular fashion, bent inward, so that you can have a proper rehabilitation of the dentation. So it is not just about reconstructing the mandible with the fibula or any other bone. We just have to consider the ideal position of the fibula, and that planning has to be done preoperatively, meticulously. So this again is a different situation in which the fibula is correctly placed, and because the bone is correctly placed, you can have a much better dental rehabilitation. And again, you see the peroneal surface of the fibula is facing outside with a better plating surface. So that becomes easy. Now, if you are doing the reconstruction in this situation and the loss of mandible is there, your double barreling is important, especially in the anterior segment, which is going up till the first molar. Beyond that, you don't need double barreling. But up till this site, you need double barreling so that there is an appropriate distance at which the implants can be placed and your dental rehabilitation can proceed comfortably. Otherwise, if there is a single segment here, then either you have to place it slightly upwards. If you place it slightly upwards, then there is a step deformity. So you have to do, there are solutions to deal with this situation, which will come in our other slides. But one way to avoid that is to use a double barreling of the fibula and have a proper dental and aesthetic rehabilitation. Now, the important thing is controlling the dentate and edentate proximal segments. Now, whatever we do, if you are not controlling the segments properly by some sort of splints or pre-plating, then what happens is then the mandible drifts because of the muscular pull outside, and you have a open bite here and some malocclusion, which almost always happen, and it's not acceptable in the present case scenario. Although the reconstruction is there, but it's a very difficult to correct problem. So to sort that out, we have to consider two more things. This is the situation in which the condyle is preserved. So If the condyle is preserved, again, we have to make sure that while doing the plating, the condyle doesn't, it's very easy to pull the condyle out of the glenoid fossa and then do the plating. And once it goes back into the normal position, the whole mandible drifts. So we have to always take care that the condyle is in normal position while doing the reconstruction and doing the plating. The third case scenario is if there is no condyle, then again there is a great risk of drifting of the reconstructed mandible, jeopardizing your final aesthetic and functional outcome. So we'll just deal with that situation by the use of full coverage splints. So these full coverage splints are prefabricated, and this is going to cover the dentation, the upper maxillary dentation, as well as the dentate portion of the mandible completely. And that prevents torquing of the mandible at the time of plating and gives the correct position of the reconstructed segment. So this is very important while doing. These are the full coverage splints, which we prefabricate preoperatively to avoid the torquing of the mandible and the segment and avoiding inferior inappropriate outcomes. Now, this is a typical situation in which, although this particular view is the posterior anterior view, basically the reconstruction has been done on the right side. Although this may look acceptable to many of us, but still, I would say there is a kind of drift which has happened here. You can see this occlusion, which is this is a patient has a denture, not an implant rehabilitation, but the occlusion is not proper. Again, these situations are happening because of the drifting of the fibula, although the reconstruction looks quite appropriate on the scans, but still there is a mild deformity happening. So what do we do? Whenever possible, we retain the condyle, however small that condyle is. And if that condyle is retained, you see the outcome. There is a beautiful form is created, and it's difficult to say that the patient has been operated. These are both the post-operative photographs of the patient, and the fibula is in exact place because the multiple techniques have been used. The implants, the 3D reconstruction has been done, and implants, the models have been taken, based on which the plate has been prefabricated and pre-bent, and thereafter the precise cut has been given, the condyle is preserved, and then this kind of outcome can be achieved by plating. But in all the situations now, we are using the 3D models for pre-plating and rehabilitation, along with, as far as possible, preserving the condyle. Now again, there is a what is available is Biomet, Zimmer's Biomet total joint prosthesis, which has a two components, and in situations in which the condyle is being excised, we can reconstruct the whole segment. We can have the zygomatic component, which is fixed to the zygomatic arch where 5 screws, and this particular thing is the joint component, the condylar component. So, and this particular model, that in this patient we have used the scapula, and this all thing has been pre-printed and prefabricated, and the planning has been done, and exactly the same plan has been followed in the operation to get a good outcome. So this is the patient with the implant in place, and see the extremely good mouth opening and totally normal occlusion in this patient. So this is one way of dealing with the situation in which the condyle is going. We can have the ready-made joint. Now we have further, this is another patient in which we have used fibula, and this is a preauricular incision given for fixing the, this component is the ultra high density polyethylene, and this particular thing is the stock joint which is going on. and giving this is a extremely good outcome for this patient, which looks nearly normal. You can see this thing. This is in place. Now, what we've started doing recently is to have a custom-made prosthesis, and this custom-made prosthesis is made by CTARs in Chennai, and this is an extended TM joint prosthesis. The advantage is that we can place the fibula upwards. It need not be placed at the lower border because lower border is made by the titanium plate. This titanium plate gives the contour to the lower border of the mandible, and this fibula is shifted upwards. So this area remains empty. So the contour of the mandible is created by this custom made plate, and the fibula has been placed up, which facilitates the dental rehabilitation of the implant, and you can have a very good acceptable outcome. So this is the post-operative photograph of the patient and a totally normal occlusion. So this is with the virtual planning, we can achieve these good outcomes. And this is much cheaper than the biomet implant also. This whole reconstruction with a custom made titanium plate along with the planning, the total cost that comes with that CTAS company, which is based in Chennai, is around 70 to 80,000 rupees. So then the third problem is, another problem is when we have a major resection from ramus to ramus, from angle of the mandible to angle of mandible, there are ways of fixating the mandible with the external fixators to stabilize the segment and to achieve a proper plating. And this is the kind of pre-adaptation and fixation of the reconstructed plate, which is done before, and then the implants are fixed. What we are doing is that we take 2 millimeter K wires, and those K wires are used to fix the segments of the mandible, and these segments of the mandible are stabilized, and then the resection is done. And already a model which has been made on which the plate has been prefabricated and pre-bent is then placed thereafter, facilitating the reconstruction. So this stabilization of the segments is very important because that prevents drifting of the condyle out of the glenoid fossa, and then the final outcome regarding the occlusion is also excellent. So this is the way that we can get it. And the final thing is that to have a very good keratinized epithelium here and for the placement of implant and have a normal form and function. And the ideal scenario by which I will end is that the ideal scenario is to have the keratinized epithelium here so that there is no further inflammation and a stable implant reconstruction can be achieved for these patients. Thank you very much.
Thank you, Dr. Mohit. It was a fabulous talk. It's great to see how mandibular reconstruction has evolved, and to the extent of even putting a joint. We have some questions. The first question is, Dr. Mohit, do you mind stop sharing the screen, sir?
Yeah, I'll stop sharing the screen.
Thank you. The first question is, how to reduce implant extrusion or plate extrusion rate. This is by Dr. Jagadish Chandra again. He says how to reduce implant extrusion or plate extrusion rate. Were you able to hear the question, Dr. Mohit? I think he's, I think Dr. Mohit has gone offline. If anyone
always have a skin line over the skin line.
Hello, Dr. Mohit, can you hear me? You're muted yourself.
Yeah. Sorry.
No worries. You can repeat your answer, please.
Yeah. I'm sorry.
No worries, sir.
So the important thing is that we need to have a skin lining, proper skin lining. So we always take a skin paddle, allow it to settle uh, for the period of time, and then we lift the skin paddle, take the fat out of, take the extra fat underneath, and leave the skin lining. This keratinized lining and a good skin paddle is very important in prevention of the exposure of the plate. So your good soft tissue coverage is very important if you want to avoid plate exposure.
Okay. Thank you, sir. Then Dr. Akshay wants to know, how do you manage facial nerve while exposing the TM joint for plating it? Do
It
you
is done,
detect it?
you see, it is done with the preauricular incision, and that is generally higher than the position in which the facial nerve comes out. So we just directly go to the joint and then stay at the joint surface. So we don't generally encounter the facial nerve there at that position. We have to go slightly deeper and really look for it. It's especially important if we are having a tumor involvement in that region. Then we have to, if at all we can preserve it, we have to trace it from the tragal pointer forwards, and then we have to have a difficult dissection in that situation, and maybe a much bigger exposure. But in these particular situations, we just directly go to the condyle and we don't encounter it.
Thank you, sir. And is it okay if I just ask the comments from the other speakers if they had any other experience, Professor Tsao,
Yes.
or Iyer, any other
Yeah.
getting the facial nerve?
Absolutely.
Uh, I would no, Vidya, I would agree that I would agree to what Mohit said. You would, one is if you are going from below, marginal mandible is at a problem, go directly to the mandible, go keep to the periosteal plane, you are safe. Preauricular, you go deep directly. You have landmarks, and then the frontal branch is the one which goes maybe near, which also is, it can be. I don't think the mostly traction. That is the cause for facial palsy. So don't get the assistants carried away by giving you good vision by pulling it too much.
Okay. Thank you, sir. Professor Tsao, any comments?
Yeah, okay, thank you. I enjoyed this talk very much. I learned a lot. Yeah, I just about one comment about can you hear me? Yeah.
Yeah, I
On the,
yeah, I think somebody's muted. Yeah.
Yeah, I know that when you
Professor Tsao, you're muted. You're muted. Yeah, it's good.
It's now okay?
It's okay.
Oh, sorry. Yeah. And I have comment about use the contralateral fibula to reconstruct the mandible, and then can use the skin pedal for lining reconstruction. And then I think this is also associated with the direction of the pedicle. If the pedicle, as he mentioned about the go posteriorly or go anteriorly. Yeah, go posteriorly, then you can use the superior thyroid artery or use the superficial temporal artery. And then maybe go posteriorly become better. But sometimes if you change the direction, if you want to use the contralateral facial artery, and then you need to, your pedicle go to the contralateral side, I think maybe you need to shift to the ipsilateral. So it's associated with the skin pedal and the relationship you select the recipient vessel. So it's not totally just follow the contralateral side to the oral line in the skin pedal. And sometimes if you harvest the skin pedal bigger, larger, longer, and then you still have possibility to reconstruct the lining part. And this is my comment. And
what about the facial nerve? If you're reconstructing the condyle, what about the facial nerve? Do you dissect the facial nerve or no?
Dissect the facial nerve?
Mm-hmm. for
the Kangda, if I reconstruct the Kangda area, when I cooperated the combined surgery with the oral surgeon, sometimes they suggest me just not reconstruct the Kangda area, just like a protein, become like a artificial, a new joint, like a protein joint, artificial joint. And the patient, if they are young and the other side, the joint, and then the muscle is healthy, he can compensate, and then the occlusion still can keep. So we still only reconstruct to the ramus label. We will not reconstruct as high to the Kangda area.
Okay, sir. Thank you very much. Mohit, sir, you have some more questions. This is from Dr. Gaurav. He says, in the double barrel technique shown, where is the pedicle kept and how are the two segments of the barrel stabilized?
So you see, first of all, you can stabilize them by small mini plates. So anterior to the segments, you can put 2 mini plates to keep the segments together. And regarding the pedicle, it all depends what is the availability in your neck, but it is generally kept ipsilateral, but it can be any way around. You can just orient it in a fashion and then plan according to where you want to keep the surface. It can be on any direction, but generally we keep it ipsilateral. And the segments are stabilized by putting 2 mini plates anterior to the segments, so keeping them together.
Right. And Dr. Gaurav asks the same, in the second case of posterior mandible ramus reconstruction with the fibula, how was the condylar segment reconstructed? In brackets, he says this case was shown to have better occlusion and dental rehabilitation.
Should I go to the presentation?
The second case of posterior mandibular ramus.
Just a minute. So, second case of ramus. Yeah, the second case which I showed is, second case is the condyle is preserved.
Okay.
So the condyle is preserved, and the pre-operatively we have taken the 3D models, and those 3D models, on that 3D models, the plate was already prefabricated, and condyle is placed, condyle is preserved, and the IMF is done, and after that resection is, basically the plate has already been prefabricated on the models. So after that, once a resection is done, once it is joined to the condyle, it just keeps it in place because there is no associated drag or lateral tension on the plate, because already we have achieved IMF, and the plate is exactly molded according to the three-dimensional planning that we have done pre-operatively.
Okay, sir. And Dr. Filippo, he's currently in Chung-Kan and he spent some time with us. Filippo Marchi, he says, do you think mini plates can play any role?
In?
Do you think, what is the role of mini plates? Mini plates for fibular mandible reconstruction?
Many times when the tissue is not good, and if we feel that our reconstruction plate will be exposed, so first we do the reconstruction with the reconstruction plate, and once that thing is achieved, then we put mini plates to keep the thing in position and take away the reconstruction plate. This we have done in some situations in which we feel that there is a chance patient is going to get radiotherapy and the tissues are not good and there is a chance of exposure. So we have done fine mini plating above and below the reconstruction plate, and finally remove the reconstruction plate. So that also is possible.
Once you get the construct all set, you remove the recon plate and just leave with the mini plates.
Yes.
Okay. And Dr. Ketan Shah asks, do you worry about condyle avascular necrosis or ORN if small residual condyles are used for fixation, and the need for post-op adjuvant treatment?
Sorry, I didn't get it. Can you?
So he's asking about avascular necrosis of the condyle when there's a very small condyle. And when
That condyle, what is remaining is your the patient's own condyle.
Okay. But is there a possibility of avascular necrosis of the condyle?
I'm sorry, I have not encountered this, but I think some Dr. Iyer, if he's here, he can comment. But I have not encountered such a situation. So
Yeah.
Dr. Iyer could
Yeah,
comment.
I can see if you usually they work. That's all. And I don't think anybody would have a lot of big experience on that. What you are worried is mostly the keeping the condyle in that position. Some amount of resorption might occur, but usually that it will work. That's what I think. We have done about 4 or 5 so far, and all of them have taken.
Okay, sir.
Because we have not encountered, I have not encountered that.
You do it mainly for benign ameloblastomas or other cysts rather than a malignancy. So there are no radiation, so they work.
Okay, sir. The next question is Dr. Sandeep. He's asked, is free fibula used in the lower end, and can dental rehabilitation still be done? I think he means lower end of the mandible, the lower border of the mandible, I think.
Yeah, it can be done, but then you will have to, your whole dynamics of the implant placement, that there is a greater stress on the implants because it is away from the tooth region, and because of that, there is a chance of more mobility because of the more stress on the implants. So it is possible. It is always. A lot of people are doing it, but it can always be done better if the bone is closer to the final position of the teeth that you are planning to have with the implant.
Okay, sir. Thank you. So
you'll have to use longer implants.
Longer implants. Okay.
With more stress.
We'll go to just one more question, and then we go to the next talk, and then the rest of the questions we can deal almost close to the end of the webinar. The next question is, how does prosthesis from CTAs respond to radiation?
I think we have used these prostheses with CTARs in ameloblastoma reconstruction, and till now we have not given radiation in these patients because these are benign. So I cannot comment on that, but it is a very high quality, good quality titanium prosthesis, and means it will, like the radiation effects will be there anyway. The tissue damage would be there, but I have no experience with this.
Experience. Okay, so I'll go to the next talk in the interest of time. Then we can come back after the other talks. You have a couple of more questions, Dr. Sharma. So it'll be great. Stick around for some time. So I'll just share the screen. The next speaker is Dr. Andrew Foreman. He's a consultant otolaryngologist and a senior lecturer at the Royal Adelaide Hospital and the University of Adelaide in Australia. Following his otolaryngology surgical training in Adelaide, he undertook fellowship training in head and neck surgical oncology and microvascular reconstruction at the University of Toronto and Princess Margaret Cancer Centre in Canada, before returning back to Adelaide, where he currently works. His research interests include the role of microbiome in oral cavity cancer and next generation tracers for sentinel lymph node biopsy in head and neck cancers as well. Besides his clinical interest in head and neck reconstruction, he also does robotic head and neck surgery, and he also has a PhD in the role of biofilms in chronic rhinosinusitis. He's published over 50 peer-reviewed journals and written in book chapters, and regularly speaks at national and international meetings, as also being faculty in multiple head and neck courses in Australia. He will be talking about pharyngeal reconstruction, the various concepts and techniques. Dr. Foreman, you can share your slide and your presentation now. Thank you.
Thanks very much, Vidya. Thanks for the introduction, and thanks for the opportunity to speak today. I'm just going to share my slides now and then get underway. So I'm going to discuss some of the principles of the reconstruction of laryngopharyngeal defects, and In this talk, I'm going to give a brief outline of disease background, really what we're talking about and the sort of patients we're likely to need to reconstruct with these defects and what that means for reconstruction. I will discuss the reconstructive options and also run through what we use here in Adelaide as an algorithm-based reconstruction protocol and discuss some of the evidence around that. So what we know of advanced laryngeal cancer is that back in the early and mid-90s, the major trials that we know in this area, the VA trial, the RTOG 9111, showed a shift were followed by a shift in primary treatment away from surgery towards primary non-surgical therapy with chemotherapy and radiotherapy. And whilst successful in disease control, larynx preservation was in the order of 60 to 80% in those studies. We do know that the long-term laryngeal preservation was significantly lower. And this has certainly been looked at, and the patients in the RTOG 9111 trial were subsequently reviewed then in 2003. And 25% of those patients who had survived with their larynx went on to require salvage total laryngectomy, either for cancer recurrence or for dysfunction of the larynx. These patients were more likely to have persistent disease, even in those with dysfunctional larynx as their indication. And they certainly identified that complication rates, and in particular pharyngocutaneous fistula rates, were significantly higher in these cases than in primary total laryngectomy, which is what we all understand for our own practices. If we move on to hypopharyngeal cancer, which will also be covered in today's talk, we know rare head and neck cancer subsite typically presents late with a relatively short survival, high rates of second malignancy, and these patients typically have other comorbidities and a poor nutritional status. And all of these things really impact on decisions that we make around reconstruction of hypopharyngeal defects and what the outcome needs are for these patients. So what we have here is patients with a poor protoplasm, with a fairly dismal disease outcome, and a significant defect that we need to consider reconstructing. And so what we really want for these patients then is short operating time, reliable reconstructive techniques, and to maximize their quality of life. The history of pharyngeal reconstruction goes a long way back and certainly has progressed on since the 1800s. The Wookie two-stage reconstruction was a very reliable approach used in the mid-1900s. Gastric transposition became a feature of this type of reconstruction in the 1950s. The deltopectoral flap was first described by Camden in the 1960s and proved a workhorse until the pec major flap was described in the late 1970s. And this became a real workhorse in pharyngeal reconstruction until the advent of microvascular reconstruction. So overall, when we consider laryngopharyngeal defects, our reconstructive aims are to produce a patent pharyngeal conduit that will permit speech and swallowing and minimize morbidity. And what we're looking for here is to create a pharyngeal seal and prevent fistula formation, prevent stricture formation in the short and long term, and also provide patients with a reconstruction that can withstand their adjuvant therapy. So ideally, the way that we work things here in Adelaide is that we have a two-team approach to reduce operative time. We try to use the most reliable reconstructive options, which, as I say, reduce fistula rates, stricture formation, and donor site morbidity. And then we optimize post-operative care. These are single-stage procedures, rapid return to swallowing and normal diet, and hopefully leave the patient with an intelligible voice. So when we consider choosing different reconstructive options in our patients, we consider tumour factors, patient factors, and surgeon factors. And in particular, the tumour factors are going to form the basis of the algorithm that I'm going to run through in just one moment. So if we consider reconstructing different defects, what are the things that we look at and how does this influence our decision making? Well, the extent of pharyngeal resection is the first and foremost consideration. Do they have any pharyngeal resection? And is it just purely total laryngectomy? Do they have a partial resection, or do they have circumferential total laryngopharyngectomy? Have they had prior radiotherapy or chemoradiotherapy? And is there a skin defect likely to be present? And I guess the most common time when we see a skin defect is patients who have prior tracheostomies, and the skin around the tracheostomy becomes less than ideal to use, and we end up excising a significant proportion of that skin and hence need to replace that. So these are the key considerations that are going to form part of the algorithm that I'll talk through in the coming slides. So when we consider pharyngeal resection or reconstruction, we first consider the resection. Is there no pharyngeal resection, partial or circumferential, as I've just outlined? In those patients who've not had pharyngeal resection, have they had prior radiotherapy? If they've not, then we would just go for primary closure with no need for flap augmentation. If they have had radiotherapy, then we would bring in vascularized tissue from elsewhere to cover the pharyngeal closure. And I'll talk about the evidence in a little while. The next consideration is that they have a skin defect. And if they have a skin defect, then we would use a radial forearm free flap, which I'll describe. And if they have no skin defect, then our options are either pec major flap or fascial free flap that I'll talk through as well. When we consider partial pharyngeal resection, if it's less than a third, these patients can be closed primarily, and so they would then fall into the category of no pharyngeal resection, and follow that algorithm on the left-hand side of the screen. If they have greater than a third pharyngeal resection, then they do require augmentation of their pharynx to prevent stricture formation and to allow adequate swallowing. And again, we have the options of either pec major flap or fasciocutaneous flaps. When we consider fasciocutaneous flaps in our population, we look at their thigh anatomy. If their thigh anatomy is favorable, then we favor ALT reconstruction in these cases. Unfavorable, we proceed with radial forearm free flap, and these really are the workhorse free flaps that we use. In patients with a circumferential defect, we then need to consider the extent of involvement of the cervical esophagus. If that is involved, we would go towards a gastric transposition, gastric pull-up. If it's uninvolved, then either fasciocutaneous flaps or jejunum, and I'll talk through this. So this slide here and the algorithm I've just presented really covers all of the potential options in considering laryngopharyngeal reflux from a reconstruction from a reconstructive surgeon's viewpoint. So I'm going to talk through some of the specific scenarios. Sorry, I just got muted, but I'm going to talk through some of the specific scenarios here from our algorithm. And if we consider those patients who are having salvage laryngectomy, who've had prior non-surgical treatment, then we do know in the post-radiotherapy field they have delayed wound healing and fibrosis, and hence vascularized tissue is suggested to reduce the stricture formation and also to reduce pharyngocutaneous fistula. And this has been quite well summarized in this article from the Laryngoscope in 2014, which was a systematic review of the use of vascularized tissue to reduce fistula following salvage laryngectomy, looking at 7 articles, 332 flap reconstructions, both reinforcing and augmentation. And overall, the pharyngocutaneous fistula rate was 26%, but when we looked at those without flap augmentation, it was 31% did have some sort of vascularized tissue placed over their reconstruction. And the summary of this is that the number needed to treat to prevent one fistula is 11, and that's certainly acceptable, I think, in most people's practice in order to introduce this as fairly standard care like we have in our department. And so we do have a number of reconstructive options for this. We can consider the pectoralis major regional flap, the radial forearm, and the temporoparietal free flap that I'll talk about now. The pectoralis major is, as we know, a reliable flap. It's very easy to harvest. The operating time is short. It's within the field. We have options of either taking the skin paddle or taking a muscle-only flap, which we can use to cover the pharyngeal closure. And then if required, skin graft the muscle externally, and that gives a very good cosmetic result at the end of the day. Donor site morbidity, though, is significant with shoulder dysfunction, the cosmetic deformity, and also pulmonary comorbidity in patients who are often long-term smokers who then have a laryngectomy. They are at high risk of chest infections, and this certainly doesn't help them in that regard. So in general, we would lean towards the use of free flaps, and if patients don't have any skin defect that requires coverage, then temporoparietal fascial free flap is really our go-to flap for pharyngeal coverage in salvage total laryngectomy. And again, nice how I do it article from the group in Toronto that describes what is really an excellent flap for this particular purpose. These are some intraoperative photos of one of our cases, and then the bottom one from the article as mentioned. But you can see the large area of fascia that can be harvested. The vessels, as we can see on this right photo here, can sometimes be really quite large. The donor site morbidity really is pretty minimal as long as you avoid the frontal branch of the facial nerve. Then it's a very well tolerated flap. And in this series of 12 patients, the fistula rate was only 8%, which again sits within the realms of what was described in that previous meta-analysis, and certainly very good outcomes and support for using vascularized tissue in salvage cases. If there's overlying skin involvement, then I like to use the radial forearm with a beaver tail, where a skin paddle is taken and then fat overlying the brachioradialis and flexocarpal radialis are also taken as part of the flap. And this has been described for a number of different indications, but again, we can see on this bottom flap here where we have a skin paddle and then a beaver tail of fat. And so what I do with this is to augment the suprastomal skin with the skin paddle and then run the beaver tail of vascularized tissue up over the pharyngeal closure, and that gives a really reliable result as well. This is just an end of case photo where you can see the skin paddle in the suprastomal region, and the fat will be running north from there. When we have partial pharyngeal resection, more than a third of the circumference, then this does require augmentation. And again, we can consider either regional flaps or fasciocutaneous flaps, and both the forearm and the anterolateral thigh are in play here. There have been a number of studies that have looked at comparing regional flaps versus free fasciocutaneous flaps. And in this study here, that looked at 906 patients, again as a meta-analysis, they found significantly lower complications and certainly functional outcomes, as well as we can see down the bottom with regular diet and tracheoesophageal speech achieved much more commonly in patients who underwent free flap versus pectoralis major. And so free flaps have certainly become, again, our workhorse in this regard. We also see, again, similar results here. The pec major flap associated with higher peg dependence and increased stricture formation, probably due to the weight of the flap as much as anything, in my opinion. When we can come to consider the total laryngopharyngectomy, so the circumferential pharyngeal defect, really is important with a preoperative endoscopy to work out whether or not the cervical esophagus is involved. If it is involved, then we would lean towards gastric pull-up. The main issue with the cervical esophagus is exactly where the distal anastomosis may need to be performed, and the risk of submucosal spread in hypopharyngeal cancers as well, making this somewhat difficult once the cervical esophagus is involved. There's no specific cutoff for how low the distal anastomosis can be. I mean, obviously we try to avoid mediastinal anastomosis because of the risks of leak in that region, and in those cases gastric pull-up would be preferred. But if it's technically possible to anastomose it low in the neck, then that's would be our preference. Gastric transposition was first described in the 1960s. It really is a major undertaking for the patient, generally involving 3-compartment dissection with the neck, thorax, and abdomen, not always requiring the thorax dissection. But mortality can be up to 20% and major morbidity up to 70%. So this is a significant consideration, and really why in most cases we would lean towards tubed fasciocutaneous free flap reconstruction of these cases. Jejunal free flaps gained popularity in the 1980s. It's not a flap that we use routinely in our practice. It does again have morbidity from the donor site, generally poorer functional outcome with a wet voice with reduced intelligibility, intermittent dysphagia, and fairly high stricture rates. So we now do tubed fasciocutaneous flaps and largely use, again, the ALT or the radial forearm based on the patient's thigh anatomy, but would prefer the ALT free flap where possible. It's one of my favorite flaps. It's a very versatile flap that can be harvested in very large sizes. I'll show you what we do with it, but it can be raised as a chimeric flap or as a single flap with deepithelialized portions to create internal lining as well as skin paddles. It has a long pedicle, a robust fascial layer that can be used to augment the watertight closure, and really has very minimal donor site morbidity. So these are some photos from an ALT free flap that we did. I think actually Vidya was our fellow when we took these photos, but generally you need at least 9 centimeters of flap width. We use the Hedne key and lock method here, where an inferior dart at the bottom of the pharyngeal tube is created to be inset into the esophagus to break up the circular scar. We typically use salivary bypass tubes, which you can see here. The flap's being tubed over the bypass tube. And then in the bottom photo, we pass one nasogastric down for feeding. One nasogastric secures the salivary bypass tube to the nasal vestibule. That stitch can then be cut, and the tube can be delivered through the oral cavity on the ward when deemed satisfactory. Again, when we can see from the top here, we have the tube part of the flap. On the right-hand side, we have the deepithelialized portion here, and then a monitor paddle created here. Tube radial forearm probably predated the ALT. We do use it if the ALT donor site is unsuitable, but again, in our practice, as the literature would say, there's been high stricture rate and high fistula rate. It does leave a very large donor defect across the forearm as well. So in conclusion, there's really numerous reconstructive options for the laryngopharynx. There's a number of important considerations: the patient, primarily the tumor and the defect, and then surgeon preference. I've tried to give to you today a defect-based reconstructive algorithm that we use. It incorporates both regional and free flap options and covers really all of the laryngopharyngeal situations that we come across in our practice. I'd like to thank Vidya for inviting me again to this and welcome you to the Royal Adelaide Hospital anytime you wish to visit. Thanks very much.
Thank you, Mr. Foreman. It was a very brilliant talk, and the algorithm is certainly very useful when you're planning the pharyngeal reconstruction. We have one question. It's from Dr. Subramania. He says, any advice on suturing techniques in primary pharyngoplasty? He says, as there's no robust evidence supporting any one of it. Also, there's mechanical staplers and manual suturing. So I think he's asking which is the best suturing technique for primary pharyngoplasty.
Yeah, so yeah, look, we use either staple device, which can be very good if you've got a completely endolaryngeal tumor, particularly in non-radiated patients. Otherwise, we use an inverting canal suture technique. We use a running suture, but I mean, you can do it interrupted as well. And then the question comes down to whether you do a horizontal closure, a vertical closure, or a T closure. I think the literature would support doing horizontal closure where possible in terms of speech outcomes, but often I find that really to put the least stress on the on the suture line that a vertical closure is the easiest to do in those cases.
Yes, sir. Do you mind if I just ask Dr. Tsao also, what does he feel regarding his suture techniques? Yeah. Professor Tsao, do you use any particular suture technique, continuous, interrupted, or? Okay, could you hear the question, Professor Tsao? You're muted. Okay, hold on 1 second, hold on. How about now? Can you hear me now? Can you hear me?
Oh, now, yeah, now I can open because I cannot open the voice. I prefer to use interrupted suture stitch by stitch and use 3/0 Dexon or and blunt needle, not sharp needle. I try to, and then we need to confirm there's no any leakage. We can injection some dye and then to check there's confirm no any leakage.
Okay.
And I think this is important. Yeah, thank you.
All right, thanks. Mr. Foreman, 2 more questions. He said, Dr. Jagadish, he says, in post-radiation, hello, can you hear us? Yeah, okay. Hold on a sec. How about now? Can you?
Camera off call.
Yeah, okay.
Yeah, I can hear.
I would request, can I request the participants to mute their audio, please? Can you mute your audio, please? We're getting a lot of feedback. Could the audience please mute your audio, please? Hold on. It's still quite. I'm just muting the people who haven't muted. Give me a minute. There's a lot of crosstalk. Sorry about that. I'll just get back to you, Andrew. Sorry. You can talk now, Andrew. I'll just ask the question. Post-radiation reconstruction of pharynx for circumferential defects, when the neck skin is unhealthy, how do you manage the skin defect to close the tracheal stoma?
Yeah, so, I mean, in general, you can still get the trachea to the inferior part of the skin. You know, so that bottom part can be closed normally. And then we use that sort of monitor paddle to close the skin defect. So using an ALT, tubing the sort of proximal part of that, having a deepithelialized proportion, and then using the second bit of the skin paddle, then we inset that. And that often insets into the top of the tracheal stoma, just directly to the mucosa of the trachea. The problem with that is that you tend to get a lot of collapse as the flap swells up, collapse over the stoma. Patient often needs a tracheostomy tube for, you know, even a week or so afterwards just to maintain the patent airway. But as the flap swelling settles down and then during radiotherapy, that kind of shrinks away and opens up. So it's not a problem. But yeah, you just use the same flap.
Same flap, okay. And Dr. Gaurav asks, regarding the salivary bypass tube, what is your protocol in terms of length of time it stays in the body, and how do you secure it to avoid its accidental extrusion, and do you pass the NG tube through it or outside it?
Yeah, so it stays in for a week in the non-radiated patient and 2 weeks in the radiated patient. We secure it with a second nasogastric that we suture directly to the tube. And then we suture that to the nasal vestibule as well. And we've never had an accidental extrusion of one of those, I must say. In terms of passing the tube either through or around it, I kind of like to pass the tube through it just because it then doesn't put pressure on the flap and anastomosis and suture lines and all that sort of thing. The biggest problem with that is that in order to get the bypass tube out, you end up taking the nasogastric tube out. And if they fail a swallow study, which we give to them, then you're sort of in a bit of a tight spot. So some of my colleagues will put it around the tube for that reason.
Okay. And what is your policy for TEP placement in a primary or a salvage setting? I think for circumferential.
The circumferential, never in salvage cases. I think they've got enough things to heal up without a prosthesis. In primary ones, as long as there's some distance between where you're going to put the prosthesis in and where you're doing your pharyngeal suturing, then I probably would. But yeah, I err on the side of doing those secondarily, just to give everything else a chance to heal up. And we typically do them under local anesthetic with a transnasal esophagoscopy technique.
Okay. And is there any role of a DP flap in case you have a skin defect for above the stoma, or would you do a skin graft?
Yeah, I mean, I would probably skin graft it, and we've done that. I mean, you can skin graft straight onto the back of the ALT flap. Actually, it works pretty well. But yeah, look, I don't typically use DP flap really in anything, but that's very much a kind of salvaged flap for me.
Better to preserve that. Okay.
Yeah.
Dr. Shruti asks, regarding pre-op assessment, she wants to know that how do you predict the post-resection defect, whether it's going to be less than 1/3 of the pharynx or more than 1/3 of the pharynx?
Yep. So we do pre-op endoscopy under general anesthetic for all of these patients to assess involvement of the post-cricoid region in particular. I mean, once they're into the post-cricoid, they're almost certainly going to get a circumferential resection because it just gets so tight down there once you put margins around things. And once it kind of spills out onto the lateral wall of the piriform fossa, there's a good chance they're going to need augmentation by the time you take margins around that. Mm-hmm. And in some cases, look, we'll tee patients up for a free flap, do the resection, and then realize that we can close them comfortably primarily, and then they just don't get a free flap. So, we can still change it on the day.
Do an endoscopy. And the last question is, with regard to ALT, do you double breast using the TFL fascia and the ALT skin to prevent leak?
Mm-hmm. Yeah. I think that's quite useful. And I hitch the fascia up to the fascia lata up to the mandible or something high up in the neck to try to also help take the weight of the flap off the tongue base.
Okay. Thank you so much. We'll go to the next talk, and there may be a few more questions after the talk, so we'll come back to that. So now I would like to introduce our next speaker. Professor Tsao, I'll just quickly introduce you. Our next speaker is Professor Chung-Kan Tsao. He is the Associate Professor in the Division of Plastic and Reconstructive Microsurgery at the Department of Plastic Surgery, Chung-Kan Memorial Hospital at Chung-Kan University, Linkou, Taiwan. Professor Tsao entered the field of plastic and reconstructive microsurgery after he completed his resident training of plastic surgery in the same hospital in Taiwan in 2002. He specializes in reconstructive microsurgery, especially reconstruction of the head and neck and esophagus. And since 2014 to 2020, he has been the chief of the Division of Plastic and Reconstructive Microsurgery at the Chung-Kan Memorial Hospital. From 2003 to May 2020, he has performed around 1,940 flaps, free flap transplantation, and which included more than 1,800 cases of head and neck reconstruction and more than 170 cases of esophageal reconstruction and 50 cases of synchronous esophagus and voice tube reconstruction. He's been in collaboration with the Department of ENT at Chung-Kan for a long time and has been more interested in improving the repair and reconstruction methods after total laryngectomy. And he successfully developed the J-design thigh flap to complete the reconstruction of the esophagus and the voice tube simultaneously, thereby helping 50 patients to restore the function of oral feeding and also solving the problem of inability to speak and communicate after surgery. With very good outcome, he was able to assist and socially integrate these patients with their new voice. So Professor Tsao will be talking about innovative techniques, mainly his innovative techniques of flap design and insets in head and neck reconstructions. Professor Tsao, I'll hand over the screen back to you, and the stage is all yours. You can now share your slide, Professor. Dr. Tsao? Hold on.
I cannot open it. Oh, now, yeah. Oh, okay, now I can open.
Okay.
Can you see this?
Um,
The file? Can you see this?
I can hear your voice, but we can't see your screen. Hold on a sec. Yeah, we can see you, but we can't see your screen. Could you?
You cannot see the screen? Can you see the?
We can see now. We can see now.
Oh, you can see now? Okay,
Yep.
okay. And then I open the slide. Okay,
Yes.
can you see this?
Yes, we can see that. We can start the presentation.
Okay, thank you.
Thank you.
Thank you for your kindly introduction, and thank you for invitation. It's
My
my great pleasure to share my experience about head and neck reconstruction. And today I'm going to share my my personally flap design and inset, 4 different parts. And the first part, I will use the delta inset side flap for hypopharyngeal cancer reconstruction. And here we see here is a segmental cervical esophageal defect. As Dr. Foreman mentioned, we traditionally use it to use the pharyngeal flap to reconstruct the defect, to bridge the esophageal defect. And here is the pedicle and the monitor loop. And here's the outcome. And sometimes we use the pre-tubed LT flap to reconstruct the defect, especially for this is a very long esophageal defect. We need to design a longitudinal tubed LT flap to reconstruct the defect. And also we externalize the skin pedal for monitor. But now more and more patients, when they referred for salvage excision and reconstruction because of failed chemoradiotherapy of hypopharyngeal cancer. And then we can see there is a segmental esophageal defect. And also we can see a friable blood vessel exposed here. And also the left interjugular vein is ligated and also SCM muscle removed. So this is not well protected. And then we know the carotid blowout is very dangerous and the mortality rate is high. And once after reconstruction, there's leakage and then the toxic drainage around the friable blood vessels may increase the risk for blowout. So since the flap loss and death are irreversible and potentially preventable, so these are our primary concerns. In this report, we present a refined design and inset method and try to deal with this problem to protect the friable blood vessels and then to divert toxic drainage once the leakage happened. And here is the delta inset side flap, the design. We use a trapezoid part, try to tube it and then to bridge the esophageal defect. And then we use additionally a trapezoid part, deepithelialization, and then to cover the major vessel. And then the distal part externalized for monitor. And in the cross view, we can see the flap inset like the Greek letter delta. Here, tubed for esophagus. And this part deepithelialization and cover the friable vessel, and then can divert toxic drainage. And then this part externalized for monitor. And we can put the pedicle to the contralateral healthier side. And here is my design, the flap, and then the harvest the flap. And the inset, here we can tube it and then to bridge the esophagus. And this part is a friable blood vessel without protection. So we can use the deepithelialization area to protect the vessel. And then we can externalize partial of the skin for monitor. And then we can confirm the circulation of the flap. And then the pedicle we use to the healthier side. And this is the outcome. And then the LT flap can provide adequate bulky of the neck and also a good monitor. And by using this method, we had already achieved no perioperative complication requiring respiration, and also very important, no deep space infection, abscess, or other life-threatening complications. We have only the late complication. We still have the fistula structural occurrence in 5 cases, and emphysema occurred in 1 patient. And then we shift to the second part. The second part, I will talk about the reconstruction of the speech function. We use the J-flap reconstruction for the speech. Without the reconstruction, we know we can use the external voice device to restore the speech. Here, demonstrate the speech. This is the pneumatic larynx. The patient can use this to talk, but the sound like a toy, and the saliva will accumulation into the tube, and then the patient need to shake the tube, and then he can keep on going to speech. And patients, sometimes they don't like to use this in public. And this is electronic larynx. So the electronic voice look very unclear, and the sound like a machine. So patients also like to use it in public. And esophageal voice. And the patient, the speech, the sound also not very clear. And the sound like the chicken crackle. Then we move. And this is the speech voice generated by our voice tube. The patient can clear speech more than 10 words in 1 breath. It's not difficult. And the vibration rate of the voice tube can up to 100% after training. And this sound is similar to a natural human sound. The voice tube replaces the function of the vocal cord. And we just modify our previous delta inside side flap. Once the vessel, we don't need to protect them, then we can use the extra side to generate a voice tube. The design is like here is the same. We tube the LT flap longitudinally to bridge the esophagus. And then we generate another transverse tube to become the voice tube. And then here is the voice tube, and here is the esophagus part. So it looks like the English letter J, so we call it J flap. And if the patient, the margin of the tumor can free, and the sheath of the carotid artery is intact, and it means not friable. And the relatively good prognosis, the flap is pliable and the length is adequate of the flap, then we can do this kind of design. Here is for the esophageal bridge, and then additional voice tube. Here is the inner orifice and the outer orifice close to the tracheostoma. And then here is the outer orifice of the voice tube. And then we can use the thumb to guide the airflow into the tube, and then back to the esophagus, and then go to the oral cavity, and like play a trumpet, and then make some voice, and then the patient can speak, and they can sing it. And here is the design. The flap here, also the trapezoid part, and the harvest of the flap, and then we can deepsization partial of the area, and then we suture the voice tube to generate the voice tube, and then here insert the bridge, the esophagus, and here is the inner orifice of the voice tube, and then here is the outer orifice of the voice tube. And if the esophageal defect is not circumferential, it's only the posterior pharyngeal wall is intact, then it becomes like a patch defect. Then we can design a patch skin paddle to reconstruct the esophagus area. And we can also generate a voice tube to reconstruct the voice. The voice tube, we can either generate it before we take off the flap. And then we start to insert the flap in one side, and here is the inner orifice of the voice tube. And then we put a stent, and then complete the repair of the esophagus. And then here is the voice tube, and then the external orifice we fix to close to the tracheostoma area. And the pedicle can go to the ipsilateral side or either to the contralateral side. About the rehabilitation, the voice tube will stented for 3 weeks. And the training will start with teach the patient to generate the voice like R or E, try to make some voice. And then the phonation and the briskness and roughness and were a little bit streaming within 3 months. After 3 months, this will become improving. And the constant air injection through the voice tube to reduce the risk of obstruction is very important. And speech therapists join the voice rehabilitation once the patient can count to 10 in one breath. And with vibration rate of the voice tube can reach 80%. And the voice tube function, about 70% of my patients can use the voice tube as their primary phonation method. And 3 patients convert the use of voice tube to external voice device. And 2 deceased patients never participate in the voice tube training. And all of my patients can resume the oral intake. About 75 patients achieve the full diet. And the raw phonation efficiency is about 75%. The average maximal phonation time was about 8.9 seconds. The average number of counting in a breath was about 14. And about the quality of the voice, the loudness and fluency and intelligibility in the first review is not very well. And then as time goes by after rehabilitation, it will getting better and better. And about the briskness, roughness, stringing, and the pitch, in the first review also not very well. And then as time goes by, it will getting better and better, except the pitch, still the same pitch sound. And here, most of our patients can achieve the conversation level. Patient come back to my clinic, they can talk with me with the voice tube. They can speak 20 words, more than 20 words very clear, the vibration rate 100%. And the patient also can complain what the symptom to me. Yeah. So if the patient, the general condition is good and the prognosis is curative, the tumor resection margin can clear and the great vessel is not exposed, then we will proceed to do the J-flap for simultaneously the esophagus and the voice tube reconstruction. However, if the patient, the general condition is poor or the prognosis is not good, the tumor resection margin not clear, and the great vessel is exposed, then we prefer to use the delta inset side flap, try to minimize the morbidity and complication. And then the voice reconstruction, restoration we use the external voice device. And here we compare the before operation and post operation, the speech quality. This is the patient's speech by the vocal cord. His speech, his address. And it's mild roughness and mild briskness and mild straining because after concurrent chemoradiotherapy, there is the auxiliary radionecrosis of the trachea. And he cannot swallow. So the patient asked to do the total laryngectomy and do both the swallow and the voice reconstruction. Oh, the similar, but the sound a moderate streaming. But after rehabilitation for 6 months, the patient can sing a song. And some patients, they have synchronous cervical esophageal cancer and the hypopharyngeal cancer. Then we need to do the gastric pull up. And then we can combine with the J-design LT flap and to restore the voice function, speech function. Here is the gastric tube pull up, and then we can repair the posterior esophageal wall to the hypopharynx area, and then become like a patch defect. Then we can use the flap to restore, reconstruct the esophagus, and then also use the voice tube to reconstruct the speech function. And this is before operation, the patient's speech with vocal cord. And this is the patient use the voice tube. And this is another case. Similar, they have synchronous esophageal cancer and hypopharyngeal cancer. So the gastric tube pull up to here, and then the suture the posterior wall. And then we use a patch skin to reconstruct the esophagus. And also again, the voice tube external orifice. And this is the speech outcome. And even after radiation, the patient still can keep their speech function well. And the patient can use the cell phone to talk with their friend. And patient can either sing a song. Okay, then we move to the third part. The third part, I will talk about a refinement of the flap inset for barcode defect. Yeah, I call this is origami concept. Then because we harvest the flap is a flat form, we have to make it concave because the oral cavity is a concave cavity. So if we can use this method to generate a concave flap, then the teeth will not compression to the flap. The flap will not sagging and bulging inside the oral cavity. And we can do just simple a triangle area deepthization and then suture it. And then can make the more 3D dimension and concave shape. And use this method, we can also generate the sulcus. And then we can generate like this, especially for patients if they perform the marginal mandibulectomy. Yeah, by this method, you can generate a good sulcus, and then that looks like a gingival area, and then the teeth will not compression to the flap. And this is outcome, good sulcus and the good concave. Will not limit the tongue motion. Here, the good sulcus and the concave shape of the flap. The concave shape. And then to avoid the teeth compression to the flap. Good concave. Okay, and then we move to the fourth part. The fourth part, I will present my method, the commissuroplasty method. For a through and through barcode defect, initially we designed the flap inset, use the incorporated method. It means we use the central part close to the lip area, and then with deepthization, and then we can pull the lip.
Conference is being recorded.
Yeah, and then we can let the patient can do aggressive rehabilitation because most of our patients, their etiology is bitterness chewing induced the oral cancer, and the mucosa is easy fibrotic change, very easy trismus, especially they will sometimes happen the iatrogenic trismus or microstomia. So we want our patient to do aggressive rehabilitation, and then after 3 to 6 months, and then we can do the commissuroplasty, and then to achieve the competence. And also the lip will not a notch or aberration deformity. And this is, we designed a commissure-based triangular flap on the previous flap area. And then we can turn this triangular flap into the oral lining, transposition to here, inversion, and then to dip the sulcus. And then combine with the lip advancement. And this flap can support the lip area inner part. And then additionally, there is a cheek triangular flap can advance and then support the outer part. And because have the inner part and outer part support, the lip can achieve the higher position and then will not induce deformity, aversion deformity or notch deformity, and then can easy to achieve competence and easy to control the drooling, and then will not make the open mouth decrease and still can keep the inter-incisor distance. And then as time goes by, we can, but after 2 months later, if the competence is stable, then we can stage it to excise the cheek skin and to make the cosmetic result better. Okay, my conclusion is appropriate the flap design and inset can prevent major complications and can provide a synchronous reconstruction of multiple functions and can decrease the iatrogenic sequela to achieve a predictable better outcomes. Okay, thank you.
Thank you, Professor Tsao. That was a excellent and very outstanding talk, and I'm very happy that the people in the who participated in the webinar also should be very, very happy to see your brilliant, innovative, and creative techniques. You do have some questions. Can I will start with the first question.
Yes.
There is one question regarding the voice tube by Dr.
Yes.
He says the voice tube is connected through the neopharynx. Will the food enter the voice tube or leak? I think he's asking regarding the angle. I remember assisting you for the angle of the J shape. Will the voice tube will the food enter the voice tube and leak and aspirate?
Yeah, sure. Sometimes especially the first 1 month or 2 months, sometimes they still have, especially the water leak. Water will leak from the esophagus into the voice tube and then come out from the external orifice of the voice tube. And then we can just simply teach the patient, use your finger to push on the voice tube. And then during the drink water, then you can control. And this condition can resolve as time goes by. Because the LT is relative thick flap, sometimes the voice tube is not very big. So the water leakage will not continue, usually only just a period of time. And it's rare to happen the food leakage. The food want to go out from this curved the tube to go out is relatively difficult. And we designed the outer orifice close outside the tracheostoma. So even the water leak or even the food leak out is easy to clean. It will not easy to develop aspiration pneumonia. Okay, thank you.
Okay. And another question is, with the J flap, how do you rate it over the voice processes? Do you feel it is better than the voice processes, the TEP?
Compare with the TEP. Now we just generate a study. We were cooperated with a hospital from Italy. So now we're still doing the study. But I think the TEP in the literature they mentioned, the problem is maybe easy the fistula. If the TEP puncture the hole, we are getting bigger and bigger. So there will sometimes have some fistula problem and sometimes have infection, the fungus infection problem. So still they need to deal with this problem to overcome it.
Well,
yeah.
And yes, and I wanted to ask you a question regarding the angle of the J when it comes out from the ALT. Is there a specific angle that you keep?
The angle is just actually you don't need to design you only when you do the deepization, the neck, the inner orifice area about 2 centimeters. You need to design a little bit tilt, a cephalic aspect, and then design a little bit going down, and then this can a little bit help to avoid the food or the water leak out from the voice tube.
So you're saying the opening should be pointing upwards or downwards or
upward? The neck area, inner orifice area, we can design a little bit upward, and then and then the tube become getting bigger and bigger, and then so at the inner orifice area, I prefer to use about 2 centimeter or 2 to 2.5 centimeter the skin, and the other part the epithelialization, and then suture to make a tube. And the outer orifice area, I prefer to use about 4 centimeter, and then to make the outer orifice easy to guide the airflow in.
Okay.
This is important.
So it's like a funnel, like it goes up.
Like a reverse trumpet. Yeah, the trumpet is from small to big, and the voice tube is from big to small.
Got it. That's a very, very good analogy. And Dr. Shilpa, she's asking, with regarding commissuroplasty, how long after completion of radiation when we do the commissuroplasty?
Yes. Yeah, after the radiation, we need to wait about at least 3 months, and then we can do the commissuroplasty. Yeah, any operation or any radiation procedure, you need to wait at least 3 months, and then you can do the reconstruction, and then the wound healing will be better.
And until that time, how do you feed the patient until that time?
The patient still can drink, but I will suggest and teach them use a bottle, and then bottle anterior part is a tube. They can directly pour the liquid diet into the oral cavity, and then he can eat.
You can place it posteriorly. You can push it back.
Yeah, he can push it. And also, if the patient wants soft diet, he can use a gauze, just put here and then put a tap. The patient still can eat. Yeah, just a little bit inconvenient initially, but in the first 3 months, I prefer them to rehabilitation, open the mouth more aggressively. Yeah, then can decrease the complication iatrogenic trismus.
Okay, thank you. 2 more questions. After microvascular flap, do you use blood thinners, and how long do you use any blood thinners? Anticoagulants.
Anticoagulants. Anticoagulants, if the patient is during the microanastomosis and during the flap transfer, there is no accidental occlusion of the blood vessel or any injury to the blood vessel, we ready to use the anticoagulant agent. We didn't use the aspirin, we didn't use the heparin. Yeah, we just let it like a normal. Only when during the anastomosis, we found there is occlusion happen, and then we redo the anastomosis. Or the blood clot easy to formation, and then we use the anticoagulant agent. Or after the flap transfer, we found the flap looks a little bit pale, the arterial insufficiency or venous insufficiency. Then we start to use the anticoagulant agent. Or we ready to need to use it. Yeah.
So only when you're expecting some trouble with the flap, otherwise no need to use it.
Yeah. If there any accidental happen, then any trouble happen, then we use these agents. Okay.
Okay. So one last question from Dr. Syed. What is the size of the tube over which the J is planned? I think you mentioned it. What is the size of the tube the J is planned?
The size, the inner part, inner orifice area about 2 to 2.5 centimeter to make the tube, and then the outer orifice area about 4 centimeter.
I think the word inverted trumpet is the golden word. Inverted trumpet. That's a good.
Invert the trump. Yeah, invert the trump.
Thank you, Professor Tsao. I still use your origami technique for the buccal mucosa inset. We will now go to the next talk, and it'll be good if you could stay for another few more minutes for us. In case any other questions, I'll ask you the questions.
Okay, no problem. Okay.
Thank you. The next speaker is Dr. Naveen Hedne. He's a senior consultant and clinical lead in head and neck surgical oncology at the Apollo Proton Cancer Center. He's done 2 fellowships one in India at Kidwai Memorial Bangalore, and also in Australia, Perth at Fremantle Hospital. His special interests are head and neck reconstruction, lateral skull-based surgery, thyroid surgery, speech and rehabilitation of swallowing, nutrition, and robotic surgery. He used to be the former director of the Department of Surgical Oncology for Narayana Health, especially Mazumdar Shaw Cancer Center in Bangalore. He will be talking about tongue resections and the use of various local and free flaps. Dr. Naveen, you can start your sharing your presentation.
Thanks, Vidya. I, at the outset, like to thank all the previous speakers who really gave very good insight into various things of Hedne reconstruction. And I also thank Vidhyadaran for getting our meeting. So I will start my presentation. I'll start the slide share.
Oh. 我轉快清咗佢咯。
No, I think we will.
Dr. Naveen, we can see your screen.
Just getting the share. Yeah, this one. Yeah, good evening again. So this is our center, Apollo Proton Center, where we work, myself, Dr. Vidhyadaran and rest of the team. So I will be talking on tongue reconstruction, and these two pictures I just pulled out from the net. You see the tongue is one of the most difficult organ to reconstruct as we go ahead. So these are the places quickly where I finished my training and did work previously. So we all have limitations when we talk about reconstruction. You can see this is the Colosseum of Rome. We can never reconstruct what was done, but we can only patch it up. So there are some limitations, but definitely I think we should be able to get there. What are the key considerations for successful reconstruction in tongue reconstruction? To reproduce the intricate anatomy, which impact the speech and swallowing. So especially lining of the defect, the bulk, the mobility, to keep the mobility of the tongue, and what to do with the remaining native tongue, how to insert the flap. There is also a lot of associated surrounding hard and soft tissue, how to reconstruct, how to take care, and also special senses. So in the past, there was a concept of reconstructive ladder, but we have moved on to something like a reconstruction escalator or elevator. We used to start from the reconstructor ladder used to start like a primary closure, skin grafting, local flaps. But most of the times nowadays we choose the flap depending upon the defect and the patient conditions and other problems. As I go ahead, I'll discuss in the further slides. So what are the things we look at when we consider reconstruction of tongue? So defect, we have to define the defect first, and when you want to reconstruct, when you want to close the defect primarily, and what other patient factors like age, what is the performance state, and also we need to consider donor site and patient and tumor factors. If you have a very advanced malignancy with not a very good prognosis, then we need to choose which is simple and which is more reliable. And also in the end, we need to think about patient preferences. How do you classify tongue defect? When you reconstruct mandible, as we saw, or maxilla, there is a good, robust reconstructive standardization. Whereas when it comes to glossectomy, we don't have, because when we're classifying a defect, initially, historically, it was hemiglossectomy, total glossectomy. That was the oncological concept, but with wide local excision, the oncological safety of wide local excision being established and peroral resection becoming more common, so we need to consider what to reconstruct, what not to, and when you reconstruct, what are the things we can use. So we need to quantify the defect, and when we quantify the defect, whether we can have a predictable outcome, because when you're doing a soft tissue reconstruction, it's difficult to have a predictable outcome. So there is some data or literature regarding volumetric reconstruction. When the volume of the remaining tongue is less than 30%, then more than 30%, then we usually use thin pliable flap for lining. Whereas when the volume of the remaining tongue is less than 30%, then we need to restore the volume. So what are the other things we need to consider when we do tongue reconstruction? Well, hyolaryngeal suspension, motorization of hypoglossal nerve, reinnervation with sensory nerve. Then we can consider dynamic flap. Then most of the time we are reconstructing mucosa with lining with skin. Whether we can consider secretory lining, then in a very advanced defect, whether we to consider double flaps. So there is there are a lot of classifications which are used when we reconstruct tongue. So if there's anything less than tongue with less than 1/3 with intact floor of mouth, there is a good this thing that you can evidence that you can close it primarily with keeping the tongue mobile with good functional outcome. When there is involvement of the floor of mouth, then when there is a possibility of fistulous communication, it's better to put a lining flap like a radial forearm or rocal flap to prevent the tethering of the flap. Whenever there is subtotal glossectomy, you need to replace, if the remaining tongue is less than 30%, then we need to restore the volume. If it is more than 30%, we need to line. And total glossectomy, there is definitely, there is no doubt, we need to do a volume restoration and also create a laryngeal elevation to supplement swallowing. When we reconstruct tongue with sufficient volume, it works with surrounding structures, especially buccal mucosa, palatal and pharyngeal musculature, to produce something called positive oropharyngeal propulsion pump force, pushing the bolus down. So because tongue is very much involved in swallowing and making the bolus ready for swallowing and pushing the bolus back. Then next, the height of the tongue is important when it comes to intelligibility of the speech, when the reconstructed tongue touches the palate. So two things are important. That is, one, volume, which is important for swallowing. Height is important for speech. We can see here there is a classification of reconstructed tongue depending upon the height. So you can see in this, you can see a PMMC reconstruction. The flap is flattened out with no volume, no height. You can see this other picture where you can see the tongue reconstructed with a good free flap, ALT free flap. There's a good volume and good height, which will definitely implicate the outcome of functional outcome. So how do you define defects? So the simple defects are usually mostly involving only the soft tissue of the tongue, mostly lateral border and some involvement of the floor of mouth. So these are simple defects. Then we come to like complex defects like subtotal defects, subtotal ossectomy defects, where just a base tongue is remaining or a part of base tongue is kept with loss of floor of mouth. When the disease is T4, you need to take the floor of mouth as well. So then, as I told you, we need to we have hard tissue defects, loss of teeth, bone, and you can have marginal mandibulectomy, segmental mandibulectomy. So this is the next challenge. And also sometimes on a very extensive defect like this, where whole of the mandible, including the anterior arch, is gone with soft tissue, skin loss. The just thing left here is, you can see epiglottis, you can see mucosa there. So this is one of a very challenging defect to reconstruct. So how do you decide on choice of flap? As we know, primary closure, as I told you, less than 1/3 with intact floor of mouth can be considered. Local flaps, islanded nasolabial flap, infrared flap, FAM flap, supraclavicular flap, submental flap, omohyoid flap, regional flaps which include PMMC and LD. But most of the reconstruction depends on free flap, that is radial forearm flap, lateral arm flap, ulnar artery flap, medial surrounding artery flap, anterolateral thigh flap, free LD, rectus abdominis, gracilis, and peroneal artery flaps can be considered. And also whether to include double flaps, we need to think about it. So these are some examples I will show. This is a primary, this is a small defect with only isolated lateral tongue. We can use primary closure with the tip left like that, so that sometimes initially people used to rotate the tip and make it heal, but I don't think that will give a better this thing. The best functional outcome is expected if you leave the mobile tongue free. Local flap, the problems with local flaps, there is still a role for local flaps, but there is it can be used in limited defects because the quantity of available tissue is small, and it's mostly in the local flaps are around the field of tumor. So we need to be very careful when choosing these flaps, because if you are already compromised the vascularity of the flap, you should plan the flap before we design the neck incision and do the neck dissection. And also we need to consider the oncologic safety, whether in an N plus neck, if you need to sacrifice facial arteries, branches of carotid arteries. So these are the things which we need to plan before we plan for a local flap. And also donor site concerns, that is aesthetic concerns. So this is an example of a local flap, that is islanded nasolabial flap, where a lateral tongue defect with marginal mandibulectomy is covered with a good outcome. You can see the mobile tip of the tongue would definitely function better. Otherwise, the other option would be to use a free flap or to rotate the tongue and suture, which is not a good thing. And this is another example where I've used bilateral nasolabial flaps to reconstruct almost a subtotal glossectomy, anterior glossectomy, and a marginal mandibulectomy. It is, as I told you, when you choose a flap, you should always consider the age of the patient, then the nature of the tumor, then the resource constraints, patient preferences and choices. So definitely, even anterior glossectomy can be reconstructed with bilateral nasolabial, but with an intact, if you have an intact floor mouth. If you have violated the floor mouth and you have taken the floor mouth, then the bulk is not enough to keep the volume appropriate. Then the other local flap available is infrahead flap, can be used to reconstruct small defects, again lining defects. Sometimes we can combine two flaps to give a little bit more bulk. We have used a nasolabial and infrahead flap when reconstructing a little more volume. So these are the things. Then if you consider here the donor side, this vertical scar on the neck is not a good thing. It heals with the contracture, resulting in little decreased mobility of the neck, and it's not a cosmetically desirable scar. Then there is always in reconstruction, replace like with like. See, the mucosa of the tongue is almost similar to buccal mucosa. We always line with skin, but it is possible to use islanded fan flap, other opposite to the islanded nasolabial, tunneled under the mandible. This was published by one of our previous colleague, Dr. Sean, and his team, which gives a good lining defect. And again, I would like to say that it's useful in small defects and helps in keeping the mobility of the tongue. And we can primarily close the defect in the donor side. Submental flap can be used, but there's a lot of oncologic concern, as we know. But it's a very robust flap, can be used to reconstruct the tongue. It is very close to the field. There is a good amount of literature. It can be used in N0 oral cavity reconstruction, but in tongue it is very, it's not well, it's difficult to comment, but definitely there is an oncological concern, and hair growth in men is something which you should be considerate when you're using this flap, because it results in a lot of stub. So regional flap, as we know, PMMC is the workhorse. Advantage of the flap is it gives a large good amount of soft tissue and also muscle to cover the vessels in the neck, easy to harvest and quite reliable, and the operative time is less, as we know. Disadvantages, whenever we have a big regional flap, marginal, the business end always has a problem. So it is difficult when we have very large flap and limited reach, but not in tongue. When you're reconstructing tongue, it shouldn't be a problem, but most of the time the PMMC, when you reconstruct it, usually goes down. So this is an example where we used pec major flap to reconstruct. Initially, it is good in the initial part, but once the adjuvant radiation is finished and as the time goes on, the muscle atrophies, you can see that it can go down. You can motorize the nerve, but still there are problems associated with it. Then comes the free flaps. So radial forearm flap is one of the most commonly used flaps. We know it gives one of the most thin and pliable flap for reconstruction of oral cavity, and the less amount of hair and the best thin pliable skin which can contour to the defects. Problem with radial forearm is the donor site defect, which is a concern, but can be used, and even it can be used in a little bulkier. If you need to replace the volume, a bigger flap can be used, but there are some the donor site deformity is a question mark. Then for this reason, then sometimes we consider lateral arm flap, which gives a good good thickness skin, which can be used to reconstruct hemiglossectomy defects. But it is not a good choice when floor mouth is involved, because it doesn't contour like the radial forearm, but it can be differentially thinned to get that contour. But mostly we would like to use it if there is a hemiglossectomy defect without much floor mouth or without a marginal mandibulectomy defect. You can see the donor site closure is good. It's much better than the radial forearm. Then the other we published this where we used a perennial artery perforator flap to reconstruct tongue. It's all because of the donor site again. It gives a good the pedicle length can reach up to 6 centimeters here, so the tongue reconstruction can be planned. It gives a good amount of good thin pliable flap. So this is a medial sural artery perforator flap. I have limited experience with this, but there is a good pedicle length. There are a lot of issues again with venous problems with medial sural artery flap, which is given in the literature. So there is some this thing advised to do 2 veins. There's still the reliability of the flap is not that good like a radial forearm, but the donor site morbidity is almost eliminated and the scar is well hidden. Then comes the secretory flaps. Dr. Vidhyadaran, who is moderating the session, published this paper where use a gastromental free flap harvested laparoscopically and used to reconstruct the tongue. Mostly hemiglossectomy with limited soft tissue defects of the floor mouth. Here, the advantage is you get a good secretory surface of the goblet cells. At the same time, the wetness is preserved, especially in post-radiation patient, it may be helpful. Then when it comes to a total glossectomy defect, there are a few choices. There are ALT, which is a workhorse, as we know, and there are different ways of insetting it. We have seen a hexagonal flap insetting with the tip, and we can use LD, motorized LD. You can use ALT with motorized vastus lateralis and rectus. These are the different flaps which can be used when it comes to reconstruction of total glossectomy defect. This case where we had loss of mandible and soft tissue defect, including the skin. Here, this can be used. We can contemplate use of 2 flaps, one for the bone and other for the soft tissue. Here, I decided to go with reconstruction plate for the mandible and covered with vastus lateralis and skin flap to resurface the tongue and the skin of the cheek. Though it is a compromise, we didn't put the bone because his curability and outcomes were not very great because of the advanced nature of the disease. So, as I told you, then definitely in these sort of defects, we should consider double flaps, including a bone, or you can consider iliac crest with internal oblique and skin paddle. So, but the mobility of the skin paddles independent to the bone is not so good, so it's not very comfortable to use these flaps. Probably scapula with parascapular flaps is also a good choice. Then double flap, as I told you, there is a report we published from Amrita use of gracilis, motorized gracilis with gastromental flap to reconstruct total vasectomy defect, so that the bulk is maintained, and also the elevation of the floor of the mouth helping in swallowing. As I told you, additional procedures are very important, especially hyolaryngeal suspension with whatever this thing you can see here. The defect, there's a defect. You reconstruct the defect with a good volume, then you need to anchor the hyoid to the mandible with good Crowlin sutures, so that when you swallow, the larynx is elevated. So these are just a nutshell. I've given what are the flaps which can be used with, from simple defect to complex defect, from local flap to regional flap to free flaps. The use of regional flap is limited. Mostly it is when its defect is small, you can use a local flap. When you have a big defect, we need to use free flaps to get the best outcomes. What are the take-home message? You need to quantify the defect. We need to consider patient factors, tumor factors, and resource availability, and do the best possible thing. So, in the end, I would like to say that it's teamwork which is most important. As we know, this picture shows a pack of African wild dogs. It seems 85% of the times when they hunt, the hunt is successful. When a tiger hunts, only 5% of the time they are successful. So it is a lesson to learn that when we work in team with, you get the best out of what we can for the patient. Thank you very much.
Thank you, Dr. Naveen. That was a fabulous talk and a visual treat for the eyes with all the different pictures. And also, you're stressing on your importance of team approach and close collaboration with different specialties interested in reconstruction. You have a couple of questions. I would ask you a few questions, then go over to Dr. Mohit and also Dr. Professor Tsao and Andrew for any more questions. The first question for you would be, why close a tongue defect if it's less than 20%? Can't you allow it to mucosalize? And laser works beautifully.
Yeah, see, this most of the time when we suture a tongue defect, mostly it will open up after a couple of probably a week's time. But the initial first 1 week is when we expect primary hemorrhage, bleeding, and post-operative catastrophic things. So better to suture it and let it heal. Even when if I do a laser excision, I would be happy to suture it and let it heal for a while, then mucosalize by over that. That's what I would do.
And Dr. Patil asks the same, another question, can a bilateral flap be considered when a neck dissection is planned?
Yeah, definitely. Bilateral nasolabial, is it?
He's just mentioned bilateral flap.
Yeah, bilateral nasolabial, because we don't need to sacrifice the facial artery. There is no big node sitting in one V. Most of the times we get away saving the vessel. So definitely can be considered. If you're doing a MRND or RND, then it's a different thing. But if you are doing selective neck dissection, definitely we should consider. And it's a very robust and reliable flap.
And what centimeter defect do you do for primary closure, or what is your threshold for primary closure?
So it's the measurement is not a thing you can use in soft tissue, because it's mostly tongue is relative to the body. So whenever it's less than 1/3, that's what we were that's why I was telling you in the quantification of tongue defects, you cannot say 2 centimeters, 3 centimeters, because somebody may have a bigger tongue, somebody may have a smaller tongue. So it's if the loss of tongue is less than 1/3 of the native tongue, of the original tongue, you should be able to close it primarily.
Mm-hmm. And what is your opinion on submental flaps regarding selection of patients and doing the ultrasound for the submental flap?
Submental flap, as I told you, it's been used in oral cavity reconstruction quite often, but for tongue, I really don't see a very this thing, because tongue mostly fails in the neck. Even in N0 neck, we see a lot of times come across occult nodes, metastasis. And you are considering it in early tongue cancer where you're going to compromise the oncological outcome. So we need to definitely, that's the reason I showed other local flap. And you don't consider them when you do it in a male patient, especially because of the hair growth. Usually the submental flap is good in old ladies where where they have a lot of loose skin. So primary closure is possible.
And there's another question. At times, the remaining portion of the tongue after tumor resection is very small, and suturing a bulky flap like PMMC or ALT can cause venous congestion of the remaining tongue. How will you suture the flap in such cases?
If you have good tissue, if you have adequate tissue, you don't need to tightly suture it. You just need to anchor the flap. That's where free flap helps. Whereas when you have a big PMMC or a regional flap, it's always the business end which has marginal necrosis, then you can leak. So whenever you consider, don't if you think that the rest of the tongue is congested, if it happens mostly in the anterior two-third of tongue, where you try to keep a sliver of tongue. It usually doesn't happen at the back of the tongue. So you leave, if you really want to leave that, just put few stitches and leave it to just hold on. If it doesn't hold on, then you can debride it without much problem. So that small sliver of tongue left behind doesn't matter much. And in case it doesn't help in any functional or outcome, that especially the anterior sliver of tongue, your posterior tongue, if you keep it is good. I mean, anterior tongue, sliver of tongue, it really doesn't add much because you lost all the innervation and vascularity. So better not to keep it. At least you get a good margin and leave it. Or if you keep it, if you decide to keep it, put few stitches and leave it.
Okay. And any role of bilateral pec majors for tongue reconstruction?
Definitely, it can be used, but as I told you, again, insect, all that is a problem. Again, it is the problem is as the time goes on, the muscle shrinks and the whole it parachutes. It's like a parachute. You insert the insert of PMC is like a parachute. When you insert, it's all quite ballooned up. As time goes on, it sags down and flattens down. And the volume of tongue, as I told, is very important in swallowing because that gives that split second when you put the bolus in the mouth before it goes to the larynx to aspirate. So the patient can learn to swallow around that bulky dome flap.
Okay. And I just wanted to put this question forward to Professor Tsao and Andrew. Do you have any choices for local flaps for tongue reconstruction? What would you prefer for local flaps in tongue reconstruction?
Oh yeah, thanks, Vidya. Yeah, that was a really nice talk, actually. Yeah, look, local flaps we use would be, I like the nasolabial as well. We use the buccinator flap and the FAM, so the facial artery myomucosal flap. Probably our other two local flaps that we use regularly, both for oral cavity and also for oropharynx for robotic defects.
Okay. And Professor Tsao?
Yes, about the local flap for tongue reconstruction, I have only experience about the segmental flap and also the delta pectoral. Sometimes if the patient have no recipient vessel available, and sometimes we use the delta pectoral for reconstruct the tongue, or once the free flap failure, and then we use the delta pectoral flap to replace that. And if the patient they don't want to keep on going another free flap. Yeah, and the segmental flap, we worry about if sometimes it's not reliable after the neck dissection. So sometimes we will use it if the neck dissection is selectively. Okay, thank you.
In females? Mm-hmm.
Yeah, sometimes, yeah, thank you.
So
one quick thing I would like to add, whenever we plan a local flap in oncological testing, we should plan the neck dissection and the flap and the incision of the neck dissection incision and the flap incision. So because the end, it's a big mess if you don't plan it before and you need to see the scans before. So it's very important when you cannot, after excising the tongue and doing the neck dissection, you cannot plan for the flap. If you plan for a local flap, think about it before you mark the incision and put the incision.
Okay. Thank you, Dr. Naveen. We have few questions for Dr. Mohit. Dr. Mohit, are you still there, sir? Dr. Mohit? Pradeep, can you unmute Dr. Mohit, please?
I'm there.
Sure. Sir, I think a couple of questions left over from your talk was, what is your choice of flap if you cannot use fibula for mandibular reconstruction, especially angle to angle?
You see, we have encountered this situation only once in 18 years. And in that situation, we used iliac crest. So although it was difficult, but that is possible. But if at all you cannot use a single iliac crest, then you can use two iliac crests from both the sides. That is possible. But then you have two anastomosis. But we have used a single iliac crest for angle to angle reconstruction. So you have to go a bit more posteriorly and anteriorly also. You have to take the spine of the anterior portion of the iliac crest. You have to take that. So it's slightly difficult and more morbid, but that is possible.
How many segments do you make with the iliac crest? 2 segments? Or?
You see, iliac crest bone has a very good cancellous component, and it is possible to osteotomize it. So we just do 2 more cuts in between and can mold it into the mandible shape. And it has a very good bone stock also.
So great, sir. And one more question. He says, in the second case, the posterior mandible, I'm sorry, this question has already been asked.
Yeah.
There is Dr. Nico Alexander who's asking, can you explain the use of Costa vascular bone graft for mandible reconstruction?
Yeah, we have a long-term follow-up for this thing. And what we usually do in younger people, we take the costal segment, like we take one of the rib, which is associated with the serratus anterior, and when we can do a composite reconstruction. So take the anterior portion of the rib with the costal cartilage segment, and with that you form the condyle, and we can use simultaneously latissimus dorsi also for skull base reconstruction. And we have followed up the patients with this. And one of our patients, after almost 16 years of follow-up, has shown slightly more growth on the side of reconstruction, actually. So it is growing more than what we expected, but overall outcome is very good. So that is possible, and ribs can be used for this thing with the costal cartilage that we have done.
And another question is, other than the stock joint, how do we reconstruct the condyle?
This is one of the way which we said we can take the ribs. Other than that, we can take we can fit the costal cartilage over the fibula.
Okay. And then
so we can just create a slot in the fibula and put the cartilage on top of that. We can do that thing easily. And that is feasible. Or we can just leave the bone. And even if we take the bone, we can contour the bone with the burr into that shape. That is also possible. So we have done all the ways, but basically since the advent of this joint, it becomes very simple. It gives a very stable but the cost factor is there.
Okay.
There is an additional cost if affordability becomes an issue with some patients. So I would say if the affordability is an issue, one can very well go for you can just limit the planning till the pre-plating and then provide the condyle with the costal cartilage or bone itself.
Yes, sir. Yes, sir. And Dr. Archit Kapoor asks, what are the prosthodontics related problems encountered when the condyle needs reconstruction?
See, condyle is placed obviously in the ramus portion where there is no dentation. So ultimately, we'll be using, even if we are reconstructing with the use of the stock joint and the condyle, we are using dental elastics and manage the occlusion with the elastics for some time. But the final outcome depends on the position and the molding of the plate, which has to be done on the STL models, which we already have taken up. So if that is appropriate, the drifting of the mandible doesn't take place.
And one more question, Dr. Rajendra Mittal. He says, if the condyle is removed, till what height fibula goes if we fix the recon plate having a condyle? I think he's worried about the fibula height.
Yeah, we leave a gap of around 8 millimeter or so. At least that much gap is left.
To cantilever. Okay.
Yeah, it's a kind of, you can assume like a gap arthroplasty.
Okay.
And that leave that much of gap.
Okay. And your last question for you is Dr. Kudish Ahmed. He says, Dr. Mohit, how do you reconstruct the middle third of the mandible?
So that can be done either with the one choice is double barrel fibula, or you can use the iliac crest, which is a very broader segment, and it gives you a very good bone height. So there you can avoid the double barreling. Otherwise, you use double barrel, or you use the titanium plate. What one of the methods is, you use a titanium contoured plate and fix the fibula slightly higher. So that allows the implant to be placed in more comfortable position. Otherwise, you use the single fibular segment and use longer implants, but there is a more stress on that. So everything is possible.
Yes, sir. And one question from maybe you, Professor Tsao, or anybody in the faculty can answer regarding, Naveen was mentioning a paper on functional reconstruction, dynamic functional reconstruction using the stomach flap and the gracilis flap. Would you still advocate it after so many years? How have you evolved with regarding to functional tongue reconstruction? This is basically for anybody in the faculty. Functional tongue reconstruction, any comments on that regarding re-innervating or motorizing the flaps?
You see, motorizing the flaps, that long term, actually that patient which had the best outcome in our series was a grade 4 CA, but biologically not that serious, and he is still alive. So that gives us a very long term follow up of that patient. So the thing is, it's a near total glossectomy defect. Some remnant of the tongue, around 10% of the tongue was available, and then we joined the fibula. Then we joined the gracilis to the mandible and hyoid bone and motorized one of the hypoglossal nerves. So that was there, and on top of that, the gastromental flap came and the stomach formed the mucosa. So we did 3 more such cases. The 2 of the patients died because of the disease, but other 2 remaining had a good and acceptable outcome. So other than the thing, it is a tedious 2 flap thing, and then you are taking a gastromental thing, which make complicating the situation. But we were very happy with the outcome, only for one reason, that the tongue mucosa is the only mucosa which is resistant to the radiation, and patient doesn't develop any xerostomia thereafter, even after radiotherapy. So that's a very good factor, although he doesn't have any taste, but sensation, but all other things on parameters, he was happy.
But do you think motorizing the flap or giving sensation to the flap, would that help from your experience? Professor Tsao or Dr. Iyer, could you comment on that? Dr. Naveen?
Yeah. So Vidya, I totally this thing just now. I think Dr. Mohit is just his paper. I just waiting for his thing. I think that's motorizing the flap is a very good thing. At least to keep the volume, it helps in. We don't know how much it will help in. You need a dynamic study to know that how much it elevates the tongue, but definitely it will keep the volume of the muscle what we put, and definitely keep the bulk of the tongue. If you motorize the vastus lateralis, it doesn't atrophy so much as it would if you don't motorize it. And most of the swallowing happens with hyolaryngeal elevation. That's hyolaryngeal suspension is more important. But as in that paper, it was the gracilis was anchored between the hyoid and bone and some part of the hyoid and the mandible. So that would give that hyolaryngeal elevation as well. So it's mostly for hyolaryngeal elevation to aid the swallowing. That's what I could summarize. But I think it's good to get Dr. Tsao's opinion.
So, Tsao, do you motorize any of your flaps for tongue reconstruction?
Good. And about the functional dynamic reconstruction of tongue, I have less experience about this. And because I think the tongue, the muscle is related multiple direction. It's not just only one way. So I think I ready to use the dynamic reconstruction for the tongue. And about the sensation for oral cavity, the flap, in our experience, we found if we do the sensate reconstruction for the flap, you can get the sensation earlier. However, during that period, just the patient need radiation. So the patient will complain more about the pain. So then that's why we discontinue to use the sensate reconstruction. Yeah, because the patient during the radiation, then will less discomfort, less pain formation. Yeah, and then the sensation will spontaneously recover as time goes by. It may be not so good, but still it will recover as time goes by. Okay, thank you.
There's one more question for you, Professor Tsao. Someone, Dr. Gurupal was asking regarding the DP flap, the delta pectoral flap. Do you delay it before? Do you delay the flap? The flap delay and then
the second stage do the 2-stage or 1-stage reconstruction. Yeah, it depends on if the neck, the dissection is extend to the level 4 or level 5, then you can bury the DP flap under the neck skin. Then you can do the 1-stage. However, I think sometimes the 2-stage also okay, because the DP flap related, if you harvest adequately, it's relatively reliable. The wound care is not so difficult. So but only the prolonged hospitalization. Maybe after 3 weeks later, you need to take off and then division the pedicle.
Yes, we'll just have 4 more questions and then we'll wrap up. Andrew, I know it's going to be close to midnight in Australia, so we'll close up after 4 more questions. Thanks for hanging around with us. Dr. Naveen, there's somebody asking, he said excellent talk, and he said please briefly highlight reconstruction options in vessel depleted neck or in salvage settings. What would you do?
One minute, just let me unmute the video.
Meanwhile, I can ask Dr. Andrew Foreman regarding how do you measure or how do you know which size the swallowing bypass tube would suit? How do you choose the swallowing bypass tube, or how do you ascertain the size for your patients? Is there a formula, or do you have any way of ascertaining before the surgery? What size do you use?
So we normally use either a 12 or a 14 Montgomery salivary bypass tube.
Yep.
And we basically make the decision when we're insetting the flap.
Okay. So you have the
and it
option.
probably, yeah, we have the option too. I mean, it comes in multiple sizes. I mean, I think it starts as low as an 8 actually, but 8, 10, 12, 14. And yeah, I mean, the size is probably not totally critical because, you know, it doesn't need to act as a stent per se to sort of keep the whole flap open. You really just need to, you know, keep the saliva away from the suture lines. I think it prevents fistula formation. So yeah, it's more about directing the saliva.
Even for a partial pharyngectomy.
Yeah, correct. Yeah.
Thank you. Then there's another question from Dr. Anand Murugesan. He's asking, what is the protocol for pain management you follow on your patients? I think this is a general question post-surgery.
I think somebody from other institute answers this, maybe a better this thing, because he's our pain guy.
Professor Tsao, would you like to answer regarding the pain management post-surgery? Are you particular?
Yeah, you mean just initial after the free flap reconstruction, or
just initial after the surgery? I think in the ICU or
in the ICU. Yeah, we will let the patient to select that they can use the pain control that they can control by themselves. Yeah, or we can use the morphine injection every 4 hours if the patient feel pain, discomfort, and we can add the anesthesia. And also we can routine give some NSAID or the acetaminophen yeah, keep on going. And on the morphine only every 4 hours for about 2 to 3 days. And it's enough. Yeah. This is our routine. Yeah. Thank you.
So I think we've come to the end of our webinar. I don't, if there's anybody has any question, Maxillary.
Regarding that question, who asked the vessel depleted neck,
Yeah.
I would quickly answer that. Fortunately, I had a experience to work with one of my professor, Dr. Moni, who did a lot of salvage. So vessel depleted neck is a big challenge, and we were forced to do a reconstruction in a vessel depleted neck. Mostly, we used to take the pedicle to the opposite side, which gives you the best. Whenever, even if you have some vessels on the ipsilateral side, it's better to take the pedicle to the opposite side. You have better vessels which are mostly not radiated, and some predictable thing. If you have, unfortunately, don't have any vessels, then it's I have personally no experience with that much. Like, if you don't have any vessels bilaterally, it's difficult to comment. But mostly, if there is opposite where neck is not explored, I would always like to take the vessels to the opposite side in a salvage setting.
Okay, and or else use a cephalic vein. Do you
The other options, you can use a cephalic vein if vein is not available, or if sometimes you can use the carotid stump, external carotid artery stump. So I think sir can give a bit more, because luckily I have still not had to reconstruct on so much vessel depleted neck. At least for me, I usually take it to the opposite side.
I think in Chung-Kan, they use, the reconstruction use the transvercervical artery and vein too in a vessel depleted neck. Yes, Professor Tsao, could you comment on that? The transvercervical artery and vein?
Yeah, contralateral, the suprathyroid artery and the facial artery. Yeah, usually we use. And also the transverse cervical artery. Yeah, transverse cervical artery. We also use that. Yeah. Sorry, I mean.
No worries. Thanks, Professor.
Because I think I hear like a contralateral cervical vessels, or it's a transverse cervical artery.
Nice.
Okay. Yeah.
So,
yeah, especially for when we do the ileocortical supercharge, that vessel we use it frequently. Yeah.
Okay. Thank you, Professor. I think we have finished. Oh, we got one last question. This is by Dr. Gurupal Shabda. If the facial vessels doesn't reach above the mandible in maxillary reconstruction, any other options? I think, Dr. Iyer, you got one final question, the last question of the day.
The first and last. Gurupal, I think it need not, sorry, you don't need to get the facial vessels above the mandible. You don't need that. But try to dissect it as high as possible, assuming that the fibula vessel will fall short. Mostly, if you get it at the mandibular level and drop it down from the submandibular gland, you can remove the submandibular gland if you are not doing a neck dissection, and then it should reach. Nothing to worry. I think be cautious in when you dissect your fibula. Don't stop only when you have the maximum pedicle. So I think it should work.
Okay. So we've come to the end of a webinar. Thank you so much, and thank you for the participants for staying back. I apologize for the initial trouble with logging in. Some of the people had problems logging. There was a technical problem. I would like to thank the faculty, especially our international faculty and our local faculty. I know it's pretty late at night in Taiwan and Adelaide. Thank you, Professor Tsao, for being a part of the talk and sharing your innovative ideas. And thank you, Dr. Andrew Foreman. I know it's pretty late, but you stayed on till late and giving your ideas on pharyngeal reconstruction. Dr. Iyer and Dr. Mohit, who are actually our teachers, and we spent most of our time under them, are all foundations that came from Amrita Institute. And thank you for being a part and taking it to another level with your fabulous talks. So I would also like to thank the people here in Apollo Proton Cancer Center, the ones behind the screen, and the ones who've been helping me, mute and unmute the participants, and with all the small issues. I'd like to thank Ms. Asha and Mr. Amit and Dr. Srinivas, who was a radiation oncologist who started this webinars on Wednesday. Mr. John Chandy, our CEO, and of course, Dr. Rakesh Jalali, who is our director, who encourages us to do all these academic presentations and for making this webinar a successful reality. He also wanted us to mention specifically, in a fortnight from now, we'll have a webinar on pain management. That will be August 5th by Dr. Anand Murugesan. So you can log into we'll put up the flyers. Once again, thank you all, and thank you our faculty for obliging to be a part of this. Any other questions? I will try to get them to answer on the Facebook page. We'll definitely put up the videos of these talks on the hospital's YouTube and the Facebook page, so the people who missed out can definitely have a look through it again. Okay. Thank you so much. Thank you, Professor Tsao. We will now log out, and thank you, Andrew. Take care, everybody, and good luck. Bye.